Hello. Uh, I'm Manoj Karmakar. I'm your host, and we are coming to you live from our studios in Hong Kong. A warm welcome to you all to the webinar number 8 of our webinar series of the International Symposium of Spine and Paravertebral Sonography. Before I just begin here, okay. First of all, greetings from our lovely city of Hong Kong. Thank you all for joining us virtually. Hopefully, in the near future, you'll all be joining us in person. We are all at the Prince of Wales Hospital, the Chinese University of Hong Kong. We are part of the Faculty of Medicine of the Chinese University. This event is, as I mentioned to you, most of you during the previous webinars, this is the 10th version of the ISSPS. From our humble beginnings in 2009. We've come a long way. It also is part of the celebrations of our young university. This is the 40th year of the Chinese University. This event is supported by our friends in Shenzhen from the VIII company. They are producing some really wonderful equipment, and we have had some preview of these. If any of you are interested, do get in touch with them. They will be more than delighted to help you with either a demonstration or giving you details about the various products that they are. In fact, I think they are one of the very few companies that are now using artificial intelligence in their ultrasound system. Worthwhile evaluating. We are proud to say today we have about 3,200 participants from 94 countries across the world. Thank you for your confidence in us, and we truly appreciate you joining us today. Today's sessions is going to be dedicated towards thoracic blocks, thoracic peripheral nerve blocks for perioperative anesthesia and analgesia. And I'll be joined by 5 very able individuals from across the globe, and is going to be setting up for a wonderful academic showdown on a very hotly debated topic. And hopefully all of us will have something to take away from this academic exchange. Dr. Yang comes from the Department of Anatomy of the Faculty of Medicine at the Yonsei University College of Medicine from Seoul in South Korea. He is an associate professor in the Department of Anatomy. He is considered a clinical anatomist, and having a clinical anatomist amongst us today is our effort to try to bring quality anatomy knowledge to regional anesthesiology meetings so that we can really share and learn from these very well-known individuals. Dr. Yang and his colleagues' recent work on 3D CT of the thoracic paravertebral anatomy and anatomy of other regions of the human body, particularly of the facial anatomy, has really redefined many of anatomy that we have traditionally become familiar with, particularly in the area of thoracic paravertebral block. The thoracic paravertebral anatomy has truly been redefined. And I believe it is a game changer for us who do clinical anesthesiology or regional blocks today. And I think Dr. Yang will be discussing many of his new findings with us today. Dr. Yang, welcome to this webinar, and we look forward to welcoming you to Hong Kong in the near future in the flesh. The next speaker is a good friend of mine and a great friend of the ISSPS for many, many years. He is Dr. Michael John Barrington, originally from Melbourne, Australia. He is now relocated, if I may use that word, to Portland in Oregon, anywhere he works at the Oregon Health and Science University in the United States. Michael really doesn't need much introduction. His work on safety and education in ultrasound-guided regional anesthesia is very well recognized. His data has really helped us convince all the stakeholders, be it the patient, the surgeon, or the skeptics, about the safety of regional anesthesia. He has published extensively, and he has been invited to speak at numerous international meetings all around the world. He's also, I believe, the executive section editor of regional anesthesia pain medicine section of the very well-known journal Anesthesia and Analgesia. It gives me great pleasure to welcome you back, Michael. And I believe it's quite late at night in Portland at this moment. And you being here with us is truly a testament to your dedication to education. We look forward to welcoming you back to Hong Kong in the near future. The next speaker will be Professor Andre Pier Boezaart. Dr. Boezaart is truly a giant in the field of regional anesthesia. Those of you who follow regional anesthesia will be very familiar with his work in various areas of peripheral nerve blockade, paravertebral blockade, and central neuraxial blocks. Thank you for joining us once again, Andre. Professor Boezaart is originally from Pretoria in South Africa. He did most of his anesthesia residency in Stellenbosch University in Cape Town. He emigrated to the United States in the 1990s, where he initially worked for a number of years at the University of Iowa, after which he relocated to the University of Florida in Gainesville, where he worked until he retired very recently to Still Bay in the Western Cape of South Africa. Special mention about Andre Boezaart is his development of the stimulating catheter for continuous peripheral nerve blockade that is still very frequently used in many parts of the world, including our center. Another area that he really needs special mention is his contribution to the war in Angola, where he cared for many injured patients using continuous peripheral nerve block techniques at a time when the world knew very little about it. He's today an emeritus professor at the University of Florida, Gainesville. Welcome back to the ISSPS webinar series, Andre, and we look forward to welcoming you to Hong Kong in the near future. The next speaker I may describe as Professor Pier Lundqvist. He comes to us from Stockholm in Sweden. He's a good friend of mine, and we share many common things, interests in life and at work. Professor Lundqvist is a pediatric anesthesia and intensive care specialist at the Karolinska University and Karolinska University Hospital. With more than 3 decades of experience in pediatric anesthesia and in particular research on thoracic paravertebral blocks, he has defined many of what we know today about paravertebral literature. In fact, PA is, as we fondly call him, PA, early research work on thoracic paravertebral blocks in neonates inspired most of my early research in thoracic paravertebral blockade. He has published extensively. He's been an invited speaker to innumerable international meetings. And PA, we look forward to seeing you very soon in Hong Kong in the flesh. The next speaker is Professor Yavuz Gurkan, Yavuz Bey, as I often call him. Yavuz is a very dynamic individual. He is from the Faculty of Medicine at the Koç University Hospital in Istanbul, Turkey. He's a board member of the Turkish Regional Anesthesia Society, Turkish Anesthesia and Reanimation Society, and a board member of the European Society of Regional Anesthesia. Dr. Gurkan is very active in teaching regional anesthesia, not only in Turkey, but all over Europe, in his capacity as being a tutor in the European Society of Regional Anesthesia. He's published extensively, and he has several original publications to his credit on Erector Spinae plane block. That is going to be one of the subjects that we are going to be discussing today, and whatnot, to be hearing it from somebody who is very familiar with it and uses it regularly in his clinical practice. Today, he also has the distinction of being the ESP block warrior for this academic showdown, and I'm sure he will not disappoint you. We look forward to welcoming you back to Hong Kong Yavuz in the near future. And thank you for joining us today. A couple of housekeeping things before I get the program going. This is a webinar format, so you as an attendee have limited privileges, but definitely you can ask questions. Please use the chat function to ask questions, and one of our moderators will pick them up, and if you make the cut, it'll be presented during the Q&A session. Now, we'll have two halves, so after the first three presentations, we'll have a short break. But before the break, we will have a Q&A session. I believe Dr. Yang has to leave, but if he's with us and you have any questions relating to anatomy, he will be more than happy to answer. If he's not with us because he has to attend a meeting, we will try and we'll cover it for him. Do remember to include your name and your location with your question. And remember, the next webinar on the 27th is our penultimate session. It'll be addressing some very interesting, clinically relevant topics of best practices for shoulder surgery, best practices for knee and hip surgery, including how you provide regional anesthesia for surgical surgery. That is the surgical anesthesia for primary breast cancer surgery using paravertebral block. I will do that in the next. So you're most welcome, and I hope to see you then. These are some of the textbooks that come out from our stables. This highlights most of what we discuss during these webinars. So if any of you are interested, to get in touch with our office, and we'll be happy to send them to you. Okay, so without further ado, I'd like to now invite Dr. Yang to discuss with us the anatomy of the thoracic paravertebral space and some of the 3D microanatomy findings that he and his research groups have recently identified, and the redefined anatomy of the paravertebral space. Welcome, Dr. Yang.
Thank you, Karmakar. Yeah. Nice to meet you, doctors. Thank you for giving me this honorable opportunity to be here in ISSPS. I'm Hong Yang from Korea, Yonsei University College of Medicine. Actually, I'm not a clinician, not an expert in pain medicine. I don't know block techniques very well. So today, just as an anatomist, I will just to show you my technical experience for the study of the paravertebral space. Previously, I used classical method, manual dissection or shallow stain technique to investigate nerve or vessel distribution. 3 years ago, I thought two ways my anatomy lab should go. First, improving the observational tool, and second, collaborating with clinicians. After trial and error in this year, we can provide detailed anatomy of the paravertebral space using our micro-CT technique. So what I talk about today is how to apply the micro-CT method for investigation of the paravertebral space and how to collaborate with a pain physician to help other clinicians. My old research topic is about small muscles and fascial connective tissues in the face. Unfortunately, these vulnerable structures would be very easily deformed or easily destroyed by a manual dissection. So my team had been looking for a better way that satisfies non-invasive approach, high-resolution images, and multi-direction observation. We found the micro-CT may be a good choice. It can provide minimum 5 micrometer box cell, very high resolution. As a kind of CT tool, the micro-CT has all those conventional CT's advantages, but mostly it has been only used for hard tissue observation because soft tissue has very low contrast in the CT, so not detectable. We found the contrast enhancement make the soft tissue very distinct in the CT image. So my team optimized the image enhancement protocol of the soft tissue using a contrast agent. By reviewing my previous studies of the facial anatomy, I briefly explain the steps of the micro-CT procedure. First, we harvested the sample. In this case, we did not remove the skin. Whole tissue, including skin, subcutaneous tissue, muscle, fat, and bone with the periosteum, they are harvested and blocked. Second step is to enhance tissue contrast, soft tissue contrast. Next step, micro-CT scanning. We used SkyScan system that can scan down to 5 micrometer voxel size. Thousands of individual sectional images could be obtained by the SkyScan system. And then the final 3D volume image was rendered by the reconstruction software, and proper section, proper area was chosen for optimal visualization. This image is from a very delicate soft tissue, lower eyelid. Up to now, we have studied the face using this technique, micro-CT. Meanwhile, my team and I, my anatomical team, decided to collaborate with a pain physician, Professor Kim Shin-young of Severance Hospital Pain Clinic. We worked together as a translational research unit for clinical anatomy related to pain management. At first, we simply reported topography of anatomical structures for safety or efficient sites to be injected. We measured numeric items for structures location and provide their expected occurrence. Or we used the Schiller staining technique that can comprehensively visualize the nerve twigs within the muscle. However, these measurement studies seem to be a little useless. Actually, useless, we think. We thought individual customized anatomical information would be more important. This is why we used ultrasound imaging. So in 2018, we tried to compare 2 paraspinal nerve blocks using cadaver injection. We compared anatomical spread of dye in thoracic region following ESP block and lateral laminar block. Lateral laminar blocks and ESP blocks were performed on the left and right sides of non-fixed cadavers. 20 milliliter of dye solution was injected at the TV5 level with ultrasound imaging. After then, the back muscles were dissected. We observed the fascial spreading in the back muscles in both techniques. The involvement of thoracic nerve was also investigated. Although ESP blocks had a slightly larger number of stained thoracic nerves, but both techniques revealed limitation of spreading to the PVS with posterior spreading to the back muscles. Agent delivery to the PVS would be a common anatomical principle of spinal nerve block. Next study, we provided a direct visualization of the PVS by endoscope. Here you can see, figure T, you can see the intact PVS. The ESP block with dye was performed with ultrasound imaging, and then immediately the PVS was observed by endoscope. We can directly observe the spreading of dye into the PVS after ESP block. As expected, the paravertebral spreading following ESP block increased in a volume-dependent manner. Of course, injection size, volume, direction, these are significant factors for successful blocks, yes, for clinicians, but I was more interested in the PVS anatomy itself. Actually, the term paravertebral space, PVS, is not legislated in the terminological anatomical, nor described in Great Anatomy, the established anatomy textbook. This is not an official anatomical term. Nevertheless, it has been broadly, frequently used in the clinical field. We borrowed the PVS concept from credit team in their monumental review in thoracic area, the vertebral body and intervertebral foramina form medial border of the thoracic PVS, TPVS here. And parietal pleura form its medial border. And superior costotransverse ligament SCTL, which connect with the internal intercostal membrane, the SCTL is the posterior border of the thoracic PVS. Actually, there is an endothoracic fascia between the rib and the pleura. This fascia is a thin connective tissue layer. So in my opinion, it seems to play a role as glue between the rib and pleura. So although an endothoracic fascia is kind of potential extension of the TPVS, but I think, in my opinion, physiologically, there would be less space between the rib and pleura. Anyway, these three borders make a narrow triangle of the TPVS. It has major nervous compartment, including spinal nerve, dorsal root ganglion, and even sympathetic ganglion. Although there are many brilliant studies about the PVS anatomy, but we wanted to show its anatomy more comprehensively with multi-directional approach that can reveal proper sectional image. Also, we tried to verify detailed morphologies of these sections using histological examination. Of course, conventional manual dissection would be still the most intuitive method. In addition, an injection study could give us important clues. By all these approaches, we tried to revisit the PVS anatomy. We tried to verify previous findings robustly and to present three-dimensional anatomy of the PVS more intuitively. This is a spine structure image. The pleura was removed. You can see the SCTL and its medial slit and lateral slit. And we found the costotransverse space without distinct dense connective tissue here, and ventral lamina of spinal nerve pass via the medial slit. Yeah. The SCTL formed posterior wall of the TPVS, but it was an incomplete border. In credit study, there was a gap here, gap between the SCTL and vertebral body. This gap has been known as the costotransverse foramen, CTF. Paraspinal muscles, including iliac spinae or multifidus, they are located posterior to the TPVS. So SCTL might be a boundary between TPVS and this back muscle compartment. However, some studies, including credit study, showed a narrow space posterior to the SCTL here, and you can see here. This small space could be filled with connective tissue. It did not seem to belong to the muscle compartment. It's a kind of transitional space. Accordingly, we found the SCTL here incompletely formed a part of a posterior wall of mentioned medial slit here. Medial slit of SCTL corresponded to the costotransverse foramen CTF. The ventral lamina of the spinal nerve was observed to exit through the CTF and enter the TPVS. The CTF or medial slit seem to be very close to the intervertebral foramen. We found another slit of the SCTL, and it was named the lateral slit. Actually, SCTL was located very close to the pleura. So the TPVS appeared to be a narrower space than previously known. We found the intervertebral ligament here, the ITL, to be located posterior to the SCTL here. The ITL was narrow, distinct ligament that attached neighboring tubercles. Some tweaks of dorsal lami of spinal nerve passed between the SCTL and ITL. You can see it. At the TV5 to fiber level, we observed consistent topography of the ITL, and two layers of the SCTL in sectional anatomy, histological findings, and microCT imaging. The SCTL originated from the superior surface of the fifth slip. From this common origin, anterior and posterior layers diverged, and the anterior layer was attached to the lower surface of the fourth slip. You can see also in histological findings. And the posterior layer of the SCTL was attached to the transverse process of the first thoracic vertebra. The ITL was originated from the lower transverse process and attached to the upper one, here, and here. The TPVS was located between the SCTL anterior layer and pleura. In this video, you can see distinct two layers of the SCTL. They are marked as blue color, anterior and posterior layers, anterior and posterior layers of the SCTL. You can see it. The medial slit of the SCTL here, or previously known the costo transverse foramen, CTF, was clearly shown in the microCT and manually dissected specimen. The ventral lami of the spinal nerve was passing through the CTF. After exiting the CTF, the ventral lami connected with the communicating lami here. This is another sample. The CTF appeared as a slit or foramen between fibers of the SCTL. The CTF was very close to the radiate ligament or costal head. In this video, the pleura remained between vertebral body and pleura. The intercostal vessels were observed here. The TPVS was shown between the pleura and SCTL, and intercostal vessels and ventral lami was shown within the TPVS vein and artery. From the anterior side, a posterior intercostal artery and vein and ventral lami that forms intercostal nerve. They are shown beneath the pleura. After removing the pleura, you can see two slits of SCTL, also clearly shown here. Medial one, also known as the costo-transverse foramen, and lateral slit of the SCTL. So far, it's known that there is ligament tissue between proximal part of rib and transverse process. It has been known as costo-transverse ligament here. However, in our study, there was no distinct ligamented tissue within this space. We define this space as the costo-transverse space, CTS. Although some faint fibers of the SCTL cross the base of the CTS, this space here, some faint fibers. This space was mostly filled with loose connective tissue or adipose tissue. You can see in the histological section. So we can speculate that this space, the CTS, could be a route for intersegmental spreading. In summary, we observed a potential spreading space between the space, SCTL, and back muscle compartment. Here, we termed it lateral SCTL space. The lateral SCTL space was consistently observed in the micro-CT and ultrasound imaging here, and this section, the specimen here. This space broadly connected furtherly DPVS via the CTF here and directly connected to the intervertebral foramina and backwardly the back muscle compartment. The ITL and the dorsal lamina of the spinal lobe were located within this space. In addition, neighboring lateral CTL spaces are vertically connected each other via the CTS. Previously, some clinicians recommended the injection targeting the space posterior to the SCTL. ASRA and ESRA Delphi consensus reported in the RAPM define an injection posterior to the SCTL as the intertransverse process block, ITL block. To confirm our findings in which the lateral SCTL space communicated with the DPVS, intervertebral foramina, and back muscle compartment, we performed the ITP block to inject the dye into the lateral SCTL space. After then, ambulant dissection of the posterior body wall was performed, and this dissected posterior body wall was defrosed, and 1 centimeter 6 serial sections were obtained. And then paravertebral dye spread was evaluated. Specimens showed a distinct staining pattern that highly corresponded to our anatomical findings. The dye fully surrounded the dorsal and ventral spinal lobe rami, is spread to the paravertebral region and like here, and intensively stained the sympathetic trunk. We found the segmental spreading from the lateral SCTL space injected site to the DPVS through the CTF and back muscle compartment and the intervertebral foramen. We could also observe spreading to the epidural space via the intervertebral foramen. In addition, there was dye staining pattern that implied the high feasibility of the intersegmental spreading, vertical segmenting, vertical spreading. First, the CTS was distinctly stained. As mentioned before, the CTS was mostly filled with the loose connective tissue and adipose tissue. This dye spreading pattern within the CTS strongly implied that the CTS could be an intersegmental conduit pathway in the ITP block. Second, the dye continuously stained the epidural space in some serial sections. Third, some levels revealed staining in the endothoracic fascia between the lip and pleura. In summary, we found horizontal spreading route to the DPVS or back muscle compartment from the lateral SCTA space, and intersegmental spreading route via the CTS or endothoracic fascia. In conclusion, many findings in our study highly corresponded to outcomes of previous studies. Using the micro-CT, histological examination, and cadaveric injection, we can observe and verify exact anatomy of the DPVS, SCTL, and CTF, and lateral SCTL space. My team would try to apply micro-CT to investigate other complicated structures related to pain management. Yes, this is my contact, my email address. If you have any question, please send me. Thank you for your attention.
Thank you, Dr. Yang, for the very enlightening talk. This has truly redefined many of the anatomy, and it has really brought into picture many unknowns. Although this is exciting, I think a lot of work has to be done to see the clinical applications and the clinical validity of most of this anatomical work. Thank you again for sharing this wonderful experience of yours. Okay, once again, as I introduced Michael before, now Professor Barrington is going to speak to us about Erector Spinae plane block, its sonoanatomy, techniques, and mechanism of action. The stage is yours, Michael.
Thank you, Manoj, and thank you for inviting me to a really fantastic meeting. I really admire your initiative and dedication, keeping the theme of the ISSPS alive. My internet connection is unstable, so I hope this does not interfere with the presentation too much. As you mentioned, my topic is Erector Spinae plane block, sonoanatomy, techniques, and mechanisms of action. I would appreciate the Erector Spinae block hit ground running in 2016 and quickly became very popular across a wide range of clinical scenarios for acute and chronic pain in emergency situations, and it became enormously popular. So much so that this journal nominated this block in 2017 as the block of the year, because you can imagine in the field of cardiac surgery and cardiac anesthesia, because of anticoagulation, there are not many options for analgesia. So this block has become enormously popular, enormously utilized, as I said, over a wide range of clinical scenarios. And there's been a large number of case reports, controlled clinical trials, My topic today is focusing not on the efficacy, but on the sonoanatomy, the technique, and how it works. As I mentioned before, the block, the technique was described in 2016, and most of the audience will be fully aware that this was described following treatment of a patient with severe unremitting pain due to a metastasis involving the patient's rib, and the care providers injected between the erector spinae muscle and the transverse process, and as this resulted in quite dramatic improvement in pain relief for the patient, and remarkably resulted in extensive cutaneous loss to sensation involving the entire hemithorax, implying blockade of both the ventral and dorsal rami of the spinal nerves. The technique is very simple, and what I like about it is that the patients can be positioned very similar to that required for a thoracic epidural block. Of course, you do not need to be making markings on the skin. This is really just to teach and demonstrate to the registrars or the residents that the can be reliably located a certain distance, 2.5 centimeters off the midline. Most people would orientate the transducer in a longitudinal fashion and image the end. Practitioners would use an in-plane approach from cranial to caudad, but clearly there are a number of ways that you could perform the block. So the technique is suitable to both a single injection technique and a continuous catheter technique. Very easy for experienced sonographers to locate the transverse process by tracking from laterally to medial, going from the ribs, more medial, then locate the costotransverse junction, and then translate further medial to where the transverse process is imaged, and something a little bit more dynamic, starting laterally over the ribs, imaging in sagittal plane until we locate the transverse process. And this is very straightforward for experienced sonographers, and most of our trainees can do this very relatively simply and efficiently. The technique, as I said, mostly involves a in-plane approach with a needle impacts on the transverse process and local anesthetic is injected there. And usually, you get a nice spread of local anesthetic, which lifts up the erector spinae muscle off the transverse process. This technique is very amenable to using a catheter technique, and I recommend that you inject through the catheter to make sure that it is in the best possible position. One thing that I've come to become a little bit wary about is sometimes you think you're in the correct plane, but you may not have advanced the needle as far as you should have. I just give an example here where I'm a very superficial transverse process. What I've tended to do and developed in my practice is to extend the needle over the caudal border of the transverse process, just beyond the transverse process, to make sure I'm in the best possible plane. We'll now get on to mechanism of action. It quickly became advertised as a block that would result in involvement of both the ventral and dorsal spinal rami. This was a result of the original cadaveric study that accompanied the original clinical description, where the authors stated that there was dye in the vicinity of the origins of the ventral and dorsal rami. This was a very small cadaveric study. One of the most extensive and detailed and informative studies is by our previous speaker, Dr. Yang, and he's already introduced this study to the audience. What I like about this study is that it involved retrolaminar blocks. So it's a relatively large sample. Many of the cadaver studies and many of the case series only involve a small number of patients. Showed quite elegantly that there was limited spread of the dye to involve the thoracic spinal nerves. For example, if you look at the proportion of specimens that were involved with the erector spinae injection, where it extended from T5 to T3, it's only 2 out of the 10 injections that spread even 2 segments away from T5. So although the thoracic spinal nerves were involved, and more nerves were involved on average, 3.5 versus 2 with the retrolaminar block. Although the thoracic spinal nerves were involved, there was limited spread. But this is the main point I'd like to make. Regardless of the technique, regardless of erector spinae or retrolaminar block, most of the spread was posterior. Most of the dye spread posterior to the transverse process, not anterior to involve the thoracic spinal nerves. You can see in the image on the left the deep staining of the erector spinae muscle. Both techniques resulted in deep staining of the erector spinae muscle. Both techniques spread of dye deep to the extrinsic muscles of the, including the latissimus dorsi and trapezium. Both techniques did not result in clear staining of the costotransverse foramina. The erector spinae block primarily had lateral spread along the thoracolumbar fascia, and the retrolaminar block primarily had vertical spread along the lamina. But again, I want to emphasize that in both techniques, the majority of the staining involved the back muscles posteriorly, not the thoracic nerves anteriorly. Dr. Avenezic did a similar study, cadaveric study. As with Dr. Yang, our prime goal was to elucidate the mechanism of action of erector spinae block. Our chief objective was to identify whether, if we did a mock erector spinae block adhering to the normal technical considerations and volumes in a cadaver, whether there would be spread anteriorly to involve the origins of the ventral and dorsal rami. This project involved 10 specimens and 20 sides where we injected 20 mils of injectate that contained 0.5% methylene blue. This study demonstrated extensive spread of the dye cephalocordate and laterally. Again, posterior spread was predominant, and it involved the muscles of the extrinsic muscles and the back muscles, the extrinsic and intrinsic muscles of the back. There was quite extensive spread laterally. The spread laterally was probably contained by the iliocostalis muscle. But in some cases, the spread, just go back to this image, was so lateral, it went as far as the attachments of the serratus anterior muscle. So there was extensive spread, lateral and cephalocordate, following 20 mils of injectate. However, only 1 out of the 20 injections was there spread of dye to involve the ventral ramus, and this involved 2 levels. In only 2 of the 20 injections was there spread to involve the dorsal root ganglion and the origins of the dorsal ramus. Because of the widespread spread posteriorly and extensive spread to the superficial muscles are involved with an erector spinae block. As a result of this cadaveric study, we are confident to say that the dorsal rami are likely to be involved with an erector spinae block. But because of limited anterior spread to involve the origins of the ventral and dorsal rami, and I'd just like to emphasize that was 1 out of 20 for the ventral rami and 2 out of 20 for the origins of the dorsal rami and dorsal root ganglion. Because of that limited spread anteriorly into the paravertebral space, I don't feel confident to consider this a block involving the ventral rami. Another cadaveric study, and this was a little bit more elaborate than ours, it only involved 4 cadavers where they did unilateral erector spinae blocks on 2 specimens and bilateral on 2 specimens. This was elaborate because 2 of the specimens were sent to the CAT scanner, and the radiologists and the investigators created 3D images in the sagittal and coronal plane and axial plane. And you can see in the top left image, there's extensive spread in the posterior planes, posterior to the transverse process. But the CT reconstructions do not show any spread of dye into the paravertebral space. There's no spread of dye to the origins of the nerve roots. Similarly, 2 of the specimens were dissected, and I acknowledge this is a small number of specimens, but in this dissection also, there was no involvement of the ventral rami following the erector spinae block. They also, from 2 of the specimens, they froze them for 48 hours, and then they did slices to determine the spread of dye. And these are slices that are in the sagittal plane, and in no case was there extension of dye anterior to the posterior border of the bony structures of the spine and torso. The 3D reconstructions show extensive longitudinal diffusion of the injectate along the erector spinae muscle, but with no anterior passage of the contrast. And you can see in this image, there's perfect visualization of all the intervertebral foramina, and the contrast is posterior to the ribs, posterior to the transverse process. So their main findings are wide block of the dorsal ramus, similar to our findings. At least that's what we would predict in the living human. And there was no involvement of the ventral ramus, again, similar to our findings. I'm going to move on to another study. Now, this is very different study by Adhikari. And this was an elaborate study involving 3 cadavers, and they used magnetic resonant imaging to determine the spread following both erector spinae and retrolaminar. In this study, in contrast to the previous 2 or 3 studies, there was extensive spread of the gadolinium containing injectate into the epidural space to involve the neural foramina space, to involve the intercostal nerves. Because the previous 3 anatomical studies, there was no direct involvement of the dye into the intercostal space. It was confined to the posterior border of the. And here's another image where it shows very clear spread of the gadolinium contained injectate to the neural foramina and to the epidural space. So this study by Adhikari with 3 cadavers, an elaborate study involving MRI imaging, does demonstrate anterior spread to the neural elements following an erector spinae block. And again, this is Dr. Yang's group, and he's introduced this study. But I'd really like to emphasize the novelty of this study. It was a cadaveric study, and one of their goals was to assess the impact of increasing the volume of injectate. If we give a larger volume of injectate, will that result in increased spread of an injectate of anteriorly to involve the neural elements? In this cadaveric study, they also did endoscopic evaluation. I think this is quite neat because they can disturbing the dye. What they found was that increasing the volume resulted in mostly increased spread to involve the posterior muscles and less pronounced spread to the paravertebral space. So we're getting a theme here that with these anatomical studies, that mostly the spread is being documented posteriorly, not anteriorly to the paravertebral space. Although I do acknowledge there are there's variations in the results that have been published, and Dr. Adhikari is publishing different results to the other studies. Now we're going to move on to a clinical study by Dr. Schwartzman, and this study involves 6 patients with severe chronic abdominal pelvic pain. And in their practice in Uruguay, in South America, they offer an Erector Spinae block to patients with severe chronic pain. The volume of injectate in the 6 blocks was 35 mils. It was actually 30 in 1 and 35 in 5. But anyway, 6 patients, T10 Erector Spinae block, and they also did MRI imaging from the patients to inject gadolinium-containing injectate. Now, of note, you can see there's quite marked spread of the dye into the Erector Spinae muscle. It's quite prominent. The staining is unambiguously dense in this study, or case series, I should say. But there's also spread of the dye into the paravertebral space. There's also spread dye into the intercostal space. There's also spread of dye to involve the neural foramina. So this study really shows in human patients who gave consent to have an MRI following their therapy for chronic pain, that the spread of local anesthetic is heading to the neural foramina, the paravertebral space, to the region where you want the local anesthetic to go. Moreover, there was spread of the local into the epidural space, which you can see in the bottom left image with the black arrow. Now, they do acknowledge that there was quite marked variation in the spread. For example, amongst the 6 patients, you can see that in some patients, the spread involves multiple neural foramina, for example, from T5 all the way down to L2. But in other studies, in another patient, there's very limited spread, very limited involvement of the neural foramina. And this variation is concerning, because we want a technique that has a consistent result. Also, there was variation in the involvement of the muscles. So either the intrinsic back muscles, such as the longissimus, or the extrinsic muscles, such as the trapezius. So again, we're seeing variation in the spread. We're seeing variation in the spread of local based on the involvement of the muscle. Now we're going to go on to another clinical study, and here the Erector Spinae block at T5 level mostly, with ropivacaine 0.5%, 20 mils, has been used for severe acute pain. And I've listed listed the clinical conditions where the Erector Spinae block was used. And quite dramatically, I believe 20 mils of ropivacaine, 0.5%, resulted in 9 segments being blocked. I think this is a dramatic result, or akin to what I would expect with an epidural block. I don't really understand how you can get such large number of segments blocked with 20 mils of local anesthetic. And moreover, there's limited spread, there's limited variation in the number of segments blocked in this particular clinical series. So 18 patients were recruited to this study that was aiming to evaluate the spread, the sensory block that resulted following erectospinal block at the T5 level. And the spread involved the ventral rami because the sensory block there is being measured in the mid-clavicular line. Of note, there were 2 patients out of the 18 where there was no block, so there was a failed block. So no technique is perfect, we know that. So we go to another study, another clinical study, and this is a volunteer study. The previous study was patients who were being treated for acute pain, severe pain, and treated successfully based on the report. Now we're looking at volunteers who agreed to have spinal plane block with 20 mils of ropivacaine, 0.5%. This is by Dr. Zhang. And the goal was to evaluate the cutaneous block that would occur following erector spinae block. Now, what Dr. Zhang demonstrated was that there was significant loss of cold sensation, but not involving a large number of segments. The segments that were most commonly involved were T6 to T9. There was widespread cutaneous block on the posterior thorax, but there was no extension of the sensory cutaneous block anterior to the posterior axillary line, indicating in this volunteer study that the erector spinae block is a block of the dorsal rami and it's not a block of the ventral rami. This is concerning, just as there's extreme variability in the anatomical studies, there's extreme variability in the results of the clinical studies. The previous study, clinical study, mapped out extensive blockade, 9 segments involving the ventral rami. This volunteer study has a much more restricted blocks the dorsal rami. So in summary, I'm confident to say that erector spinae block will result in extensive craniocaudal spread. But this spread is mostly posterior. It's mostly posterior to the transverse processes. Of course, some of the local anesthetic spread does penetrate its way anteriorly based on some of the studies to involve the ventral rami, to involve the intercostal foramina, to involve the origins of the spinal nerves. But my observation from our own work and reading the bulk and reading the anatomical and clinical studies is that the extent of the variation concerns me, and I'm more confident to say that this block extends posterior to the transverse process, and there's sufficient evidence to challenge the concept that erector spinae block results in blockade of the ventral rami. There's sufficient evidence to challenge the concept that somehow the local anesthetic, which is injected posterior to the transverse process, diffuses anteriorly somehow into the paravertebral space. I think if you want to do a paravertebral block, if you want your local anesthetic to involve the paravertebral space, I think you should do a paravertebral block. So what is the mechanism of action? As I've already alluded to, I'm confident the erector spinae block is a block of the dorsal rami of the spinal nerves. So it's going to be effective for treating conditions and surgeries that involve the dorsal rami. Perhaps the local anesthetic injected in this location has an impact on the thoracolumbar fascia, which, as we know, is richly innervated, and somehow that may have some positive effect on how, or be related in some way to the mechanism of action. It's possible, and we noted this in our cadaveric study, spread. Potentially, in some patients, this could get as far as the lateral cutaneous nerve. Also, there could be a systemic effect. A systemic effect is quite likely because of the large dosages of local anesthetic administered with an erector spinae block. Finally, the last reason why erector spinae block may be effective in some clinical practices. The outcome of interest is pain, and this is the outcome which is recorded in well over 90% of randomized controlled trials in the field of regional anesthesia. Measurement of pain is subjective. The way you ask the question, who asked the question, the style of inquiry influences the response you get back from the patient. Positive treatment expectations have significant effects on the analgesic effects of our interventions. In fact, Dr. Bingle has suggested that this should be taken into account in controlled clinical trials in some way, that this positive treatment effect should be accounted for, because this is a significant confounder. Positive expectation effects are particularly strong in the treatment of pain. They're particularly effective when invasive interventions are used. They're particularly likely to be effective when a new technique is enthusiastically endorsed by a group of clinician researchers. I'll finish there. Thank you very much for your attention. And thank you so much, Professor Karmakar, for inviting me.
Thank you, Michael, for the wonderful review on the block mechanism for erector spinae plane block. I couldn't commend you more for being so balanced in your conclusions. Okay, ladies and gentlemen, we're going to move gears now. I'm going to now present to you the sonoanatomy ultrasound imaging technique of the thoracic, relevant for thoracic paravertebral blocks, the different techniques, and how it produces ipsilateral sensory motor somatic sympathetic blockade. Before I begin, I'd like to declare I have no conflict of interest whatsoever relating to this presentation. For those of you who are not familiar with paravertebral blocks, if you see a red star, that's a cue for you to take home. Again, as I alluded to, these are some books from our stable, so if you are interested, do get in touch with our office and we will be happy to share it with you. Okay, my objective is to demonstrate to you the scanning techniques and the sonoanatomy relevant for thoracic paravertebral blocks, the different techniques, a brief review of the different techniques that we have today, given that there are no optimal techniques being described on ultrasound-guided paravertebral blocks. I will then try and summarize some of the mechanisms by which paravertebral blocks produces ipsilateral, segmental, somatic, and sympathetic nerve blockade. Over the years, the techniques have changed from landmark to ultrasound-guided, and with it, I think the evidence suggests that there is a change in the mechanism by which the blocks, the sensory somatic sympathetic blockade is produced. Hopefully along the way, we will answer the question, why ultrasound guided over landmarks? Why a single, or should you choose a single or a multiple injection, and for what? Whether a medial or a lateral injection technique is desirable, and what is the effect of increasing the dose of local anesthetic, particularly with ultrasound guided blocks. Now, we're in the era of ultrasound guidance, but I think if we dwell into the history, it was initially described by this group of authors from Vienna in Austria, and Austria with its traditions of ultrasound. Pier et al. Used it to measure the depth of the transverse process from the skin. Actually, the true real-time use of 2D ultrasound for paravertebral block was by this group by Hara and Dr. Sakura and their group from Spinae in Japan in 2007. Dr. Hara and Dr. Sakura and the group from Spinae in their publication in Anesthesia in 2009, described ultrasound-guided paravertebral block using 2D ultrasound. Now, when we look at the sonoanatomy of relevant for paravertebral block, I think there is some evidence today that the anatomy of the structures that you visualize may vary whether you're performing the scan in the upper, middle, or lower thoracic region. Now, since most of our discussions are for today will be in the mid-thoracic region, but I would like to caution you that the anatomy may vary slightly in terms of the depth to the pleura, visibility of the pleura, etc., and I will cover some of that as we go along. Now, when you look at the anatomy of the thoracic paravertebral spine, and particularly the sonoanatomy, I think rather than look at the soft tissue, I think first we need to focus on the osseous anatomy. As you will see, there are significant differences between the osseous anatomy of the lumbar and the thoracic spine, particularly the direction in which, or the position of the transverse process and how the rib articulates anteriorly at the costotransverse and the costovertebral junction. This creates this kind of a physical osseous pattern that you can very consistently visualize in an ultrasound image. Also, do remember that the spinous process that you see at the mid-thoracic region may not correspond to the vertebra, to the same vertebra that level that you are performing the scan. Because of the steep angulation, you may indeed be visualizing the spinous process from the vertebra above. Also, as you see here in this image, the rib articulates anteriorly with the costotransverse junction, and Dr. Yang described a lot in detail about the costotransverse space and how the rib continues laterally. Also, I would like you to pay attention to the inferior articular process. Today, a lot of attention is paid on the transverse process, but I think most of the anatomy and where most of the mechanisms are happening is at the level of the inferior articular process, that is at the intertransverse level. If you can see here, the inferior articular process articulates with the superior articular process anteriorly to form the facet joints. The inferior articular process also forms part of the intervertebral foramina, and you can see here, anterior to the inferior articular process, the nerve root emerges from the intervertebral foramina. So I like you to keep this in mind that when I show you the inferior articular process in a sonogram, you can then visualize in your mind's eye where the intervertebral foramina is located. So that's very important. Also, when you look at the sonoanatomy of the paravertebral region, particularly the sagittal sonoanatomy, one has to closely understand or clearly understand the transitional anatomy that happens as one performs the scan from a lateral to medial direction or from medial to lateral direction, as Michael alluded to in his presentation. As you will see that the structures do vary as you scan from a medial to a lateral direction. You can see here this at the level of the epidural space, where you do an epidural scan at the level of the lamina, here at the level of the transverse process, and here is at the level of the ribs per se. Why is this important? Let me illustrate to you this in this 3D ultrasound volume of a patient in a volunteer. We perform a 3D scan. And so this particular 3D volume was sliced up into multiple sections of about 1 millimeter apart. And as you can see, as we come from the medial to the lateral direction, there are about 16 slices, which are 1 millimeter apart. You can see a couple of things. One is that at the level of the transverse process, the osseous structures are more bulbous, if you may, or more rectangular in shape, and you can often see the articulation of the rib anteriorly. And as you go more laterally towards the intercostal spaces, you can see that the rib becomes more rounded and is much more superficial also in relation to the anatomy. Furthermore, if you look at the visualization of the pleura here at the level of the transverse process, it often visualized as often I would say it's more fuzzier in appearance, and you can't really get a very sharp, clear image. In contrast to that, the clear-cut pleural sliding that you can see at the intercostal level. And these are very clearly demonstrated here. And in this 2D ultrasound, you can see here, this is of the thoracic epidural space. We discussed at length in our webinar 2. You can see here at the level of the transverse process, indeed, visualizing the true pleura is actually quite difficult. You can see here visualization of the pleura is difficult, but you can see the ligamentous complex posteriorly. But when you look at the rib are much more smaller, they are more rounded, and the pleura is much more clear-cut, very well defined. Now, this is sometimes novices who do not recognize this may use this as and describe this as paravertebral injections. In fact, we have done that too in publications in the early years. Now, the clinical relevance of this is that if you perform an intercostal injection and a more lateral injection, although you may get paravertebral spread, but the dermatomal spread of anesthesia will not be as marked as it is when you do a paravertebral block. That means the paravertebral spread of sensory blockade is much more extensive when you inject at the medial part of the paravertebral space. Now, let's take a quick look at the techniques that have been described. You can perform a scan either in the sagittal or in the transverse window. The sagittal is most commonly used because it mirrors what we normally would do in a landmark-based technique. You identify the transverse processes, and then you identify the pleura anteriorly, and then you place your needle and perform the injection. I can highly recommend this review by Dr. Credit and their colleagues, which reviews most of the techniques, anatomy, and about the different ultrasound-guided techniques, and it's definitely worth considering. And you can see here, they classified all the techniques into different approaches using the transverse, sagittal, using different osseous landmarks with a lateral to medial, medial to lateral. But really, what it illustrates that there are umpteen number of techniques described, but there are no optimal techniques. Now, let's try and cover this in brief. So you can see that when you perform a sagittal scan, this is how the ultrasound beam is insulated, and this is how it would appear to you using a linear transducer. The ultrasound image, even with high definition ultrasound images, you can see the transverse process, which is bulbous appearance. The pleura is not really very clear cut, but you can visualize it where it is, and then the ligamentous complex posteriorly. Why is there poor visualization? It's not really clearly understood, but we believe it may be related to this phenomenon of anisotropy, an artifact because the ultrasound beam is truly not really at right angles to the pleura because of the anterior or medial reflection of the pleura anterior to the paravertebral space. We also found that if you just gently tilt the transducer slightly laterally, your visualization of the pleura becomes much more clearer. Now, one of the pitfalls of this lateral tilt is that you may be often visualizing the intercostal space, and thereby it may force you to perform the injection into the intercostal space as opposed to the paravertebral space. But once you're aware of this, I think it is possible to clearly define the pleura and the transverse process at the same time. When you do a sagittal scan, you can place the needle outer plane as described by Dr. Hara and their colleagues from Shimane. They perform a transverse scan, then they place the needle outer plane, and they in this study also use loss of resistance. I assume there were two operators, one performing the scan and the other performing the loss of resistance. What they found was that at the moment of truth, when you entered the space, there was turbulence with the level of the injection of saline, and there was anterior displacement of the pleura and widening of the paravertebral space. I think this is one of the earliest descriptions of anterior displacement of the pleura as an objective sign for a correct extrapleural or paravertebral injection. However, although they had 100% success in their small cohort of patients, they do categorically describe that they were unable to delineate the pleura at the T1 level. And remember, I mentioned there are some differences in visualization of the sonoanatomy at the different levels. So higher up the spine you go, more difficult it becomes to delineate the pleura. And I think this is because of the shape of the lung and the pleura in the upper thoracic spaces. More recently, the sagittal scan has also been adapted to perform in-plane needle insertion by this group from Ireland, including our group, where you perform a sagittal scan. Now, it's debatable, as I mentioned before, if this is truly the transverse process. You can now see that they successfully perform the injections using ultrasound, but they do report that it was difficult to visualize the needle as it was advanced. Now, because the angle of insertion of the needle in plane is relatively steep, it is often difficult to visualize. Even when you use echogenic needles, it can become difficult to visualize the advancement of the needle. As you can see here, we are using the slight tilt maneuver that we described. You insert the needle, and in those days, we were using these graduated needles, early days, and the needle is inserted in a caudocranial direction. Again, I admit here, this is probably the rib that we are illustrating in this ultrasound image. But nevertheless, you advance it to the lower part of the osseous structure. And because visualizing the needle can be difficult, the needle can be a surrogate to stop the needle, or you can deliberately feel the transverse process and then gradually advance the needle to inject saline till you see advancement of the anterior displacement of the parietal pleura, heralding injection into the paravertebral space. We also found that when you inject in one space, you can see longitudinal sagittal spread to the contiguous level. So this again illustrates that the paravertebral spaces communicate along the paravertebral gutter from one level to another. So what are the limitations of the sagittal scan? As I demonstrated to you, one is that there is poor visualization of anatomy, particularly the pleura. And in a technique where there is concern of pleural puncture, this may be quite relevant. There's also poor visualization of the advancing needle. So one may think, well, you're doing an ultrasound-guided technique. If you can't see the pleura, if you can't see the needle, then what kind of ultrasound guidance are we doing? And I think this is one of the major problems I faced with the sagittal scan. Nevertheless, if you use it regularly and you're an expert at using it, as Dr. Nielsen and the group demonstrated in this paper in Regional Anesthesia and the retrospective review of complications following a paramedian sagittal in-plane, pleural puncture reported was 0, although they found in postoperative chest X-ray 2 pneumothoraces, they were subclinical. So you can see that you can have pleural puncture is rare at the time of needle insertion in well-primed centers that are doing them on a regular basis. So therefore, I think it's desirable if you can really see the anatomy and the needle at the same time in an ultrasound image. I now go on to the third option that you have. You can perform a transverse scan. And as I alluded to before, now try and focus on the osseous anatomy that have been used as the backdrop for the ultrasound scan. So we are doing a transverse scan at the level of the transverse process, and the needle is going to be inserted out of plane as illustrated in this cartoon. So the transverse scan is performed like so. And in a study by Dr. Daniel Marhofer and the group from Vienna in Austria, they performed 20 ml injections in this group cohort of volunteers. And you can see here the blue represents the spread on the MRI scan, and the white bars represent the sensory spread in that cohort of volunteers, 10 volunteers. You can see here that the sensory spread is often always greater than the segmental MRI spread. You can also see that the segmental spread of sensory blockade is quite variable. So this is quite similar to what we used to see when we did landmark-based techniques, and I will come to that in a short while. Nevertheless, the needle is inserted like so, and you either contact the transverse process and advance it caudally, or as Dr. Marhofer and they contact the transverse process and direct the needle laterally till you inject saline and see anterior displacement of the pleura and widening of the paravertebral space, which can be seen through the intertransverse window. Next is the transverse scan at the level of the transverse process, but now we are going to inject in plane. This seems like a slight variation to what Dr. Marhofer has described, but in fact, Dr. Shibata and Dr. Nishikawa from Japan actually described this much earlier on, this in-plane technique. And in fact, another group from the United States also described this as an intercostal approach to the paravertebral space. This is what I describe often as the Shibata window. You can see the transverse process. So this is medial and this would be lateral. You can see anteriorly, you will see the pleura. Posteriorly, you can see the ligament complex and the internal intercostal membrane laterally. The needle is inserted from a lateral to medial direction, aiming for this apical part of this paravertebral space, which is the hypoechoic space. And then once you inject your local anesthetic or saline, we believe you should always inject saline before the local anesthetic. And if you see anterior displacement of the pleura or a widening of the space, that usually indicates placement of the needle in the paravertebral space. We have adopted this technique in a slightly different way. We've modified it and performed the scan at a slightly lower level, but at the level of the inferior articular process. Now, ladies and gentlemen, this is where what I demonstrated to you would be of relevance. Now, this is an intertransverse scan, a transverse scan at the level of the inferior articular process where the needle will be inserted from a lateral to medial direction and in plane. And this has become our go-to for ultrasound-guided paravertebral blocks. And today, we perform more than 4,000 or 5,000 individual injections and with very low incidences of complication, and I will come to that. In contrast to most other invest reports that have been described today with the use of linear transducer, you'll be surprised the quality of image that you can get with modern day ultrasound with the use of low frequency transducers. We use low frequency transducers for all our paravertebral injections in the thoracic region. The low frequency transducers are curvilinear, so they also provide a wide field of view. We perform the scan in a sequential manner. As we described the suit for brachial plexus, this is the suit for the paravertebral scan. You start the scan by identifying the osseous anatomy that you are familiar with, that is the transverse process, the lamina, and the ribs. Thereafter, you slide the transducer slightly caudate to bring about the Shibata and Nishikawa window, which is the level of the transverse process. And then if you go slightly caudate to the transverse process, in fact, all you need to do is just tilt your transducer caudate, and then you will see that you are at the articular process window. Note, the articular process is related, anteriorly is related to the intervertebral foramina, as I mentioned to you. You can see here, this is the intertransverse scan at the level of the articular process. And as I mentioned before, the nerve root emerges from the intervertebral foramina just anterior to the articular process. This is very well illustrated in this CT section. You can see the level of the rib and transverse process. You can see the spinous process of the vertebra above. Then the lamina and transverse process with the costotransverse articulation, the costotransverse space that's well defined now by Dr. Yang. And this is the rib. And then if you go just below the rib, you will see the transverse process with the paravertebral anatomy anteriorly. And if you go below the transverse process, you can now see the articular process, as I mentioned, the intervertebral foramina just located. So if you keep that in your mind's eye and you have that understanding, it's very easy to understand the anatomy. Now, in this sequence of ultrasound images, I'm going to start from the first part of our sequence, the level of the rib and transverse process. You can see the spinous process. You can see the lamina. You can see the posterior directed transverse processes. And then the costotransverse articulation where the yellow arrow is, and then the rib posteriorly. So this is really not the window to identify the paravertebral space, but this is a starting point from where your sequence begins so that you can consistently identify the anatomy. Therefore, thereafter, if you just slide the transducer caudally, you can see the spinous process, the lamina, the posterior directed transverse processes, and now, because the rib is not here, you can see the parietal pleura anteriorly and this hypoechoic space between the ligament complex posteriorly and the intertransverse ligament laterally and the pleura anteriorly. So this is indeed the apical part of the paravertebral space. While you can place your needle like Dr. Shibata and perform this injection very safely and effectively, to me, it appeared that the paravertebral space is so near, but yet you are so far. It's like saying you're so close, but you're so far. What do I mean by that? If you now just tilt your transducer slightly caudally, you can see here the transverse process shadow now disappears. You're only left with this osseous shadow of the spinous process, the lamina, and the articular process. As I mentioned, this is where the intervertebral foramina is located. Now you can see the superior costal transverse ligament, which continues laterally as the internal intercostal membrane. Anterior and medially, you can see the parietal pleura. And even here, you can see that because of the anteromedial reflection, the pleura is not very clearly delineated. But in between these structures, you can, in your mind's eye, picture where the triangular or wedge-shaped paravertebral space is located and the intervertebral foramina is located. So this is the sequence that I showed you, starting from the rib, the level of the rib, that is the spinous process, lamina, transverse process, and the rib. You go below that, you see the transverse process window, and then you have the articular process window. And this creates the osseous pattern that should become an integral part of your understanding when you are doing ultrasound imaging of the thoracic paravertebral region. I can highlight this better in this sequence of videos. You can see once again, this is another patient. You can see here very clearly that the articular process is medially, and then you have this wedge-shaped wide triangular space. So this is indeed the true paravertebral space that you are looking at as described in our anatomy in regional anesthesia. In fact, these are the outlines of the space that I have just marked out. And this is considering that this is the anteromedial reflection of the parietal pleura and goes on to the vertebral body anteriorly. Okay, this is just to show you the sequence. We are using the curved linear transducer. On the left, you can see the sonoanatomy with the rib window first. And as we just slide the transducer below the rib, okay, from here, we just slide it slightly caudally. Now you can see the lung sliding sign with the thick ligamentous complex posteriorly. And then if you just go below the transverse process, you're left with the articular process and this wedge-shaped space. Now, all you need is, if you have the dexterity, is to advance the needle from a lateral to medial into this apical part of this paravertebral space. I believe this medial part of the paravertebral space is a no-go zone, and I will give you some reasons for that. But certainly one of the reasons is that this is where the dural sleeves are, this is where the nerve roots are, and the majority of the spinal arteries are located in this area. So the in-plane insertion happens like so. This is the ergonomics, the operator, and an assistant to help with the injection of saline and the local anesthetic. This is just to show you one of the better images where you can see very clearly the costotransverse ligament posteriorly and the internal intercostal membrane with the apical part of the paravertebral space and the lung sliding. The needle is inserted from a lateral to medial direction, as you can see in this is the ergonomics. When we do multiple injections, we do from caudal to cranial in that order so that you don't miss a level. And then you can see how the needle is advanced to this apical part of this paravertebral space, like so. Since the needle is tangential to the pleura, and as that's what Dr. Shibata described many years, unlikely to puncture the pleura, but if you are careless and you don't have adequate dexterity, it's very easily to inject it into near the intervertebral foramina. So you can see here, these are other sequence. You can see here, once you inject the saline or the local anesthetic, you can see there's widening of the space, there's anterior displacement of the pleura, and spread within the paravertebral space. This can be better illustrated in this video where you can see the needle is inserted in plane. And because the needle is inserted at an angle, as you can see, it's quite relatively steep in individuals with the bigger body habitus, as in this individual you can see here. We use echogenic needles, 22 gauge echogenic needles for all our paravertebral injections. And if done so appropriately, you can see that you can even identify the tip of the needle in the paravertebral space. And once you inject your saline, you will see widening of the space, displacement of the pleura, increased echogenicity of the pleura is also another feature. It's because of post enhancement. And you can see here 3 to 4 cc's of local anesthetic at a given interspace in paravertebral space produces this kind of a sonographic appearance. So, as I alluded to before, The articular process is a friendly anatomical landmark, but also it is associated with the intervertebral foramina. And as you can see here, the dorsal branch of the spinal artery is emerging from here. So the spinal arteries are all located with the intercostal artery. And this, I believe, is currently the no-go zone as far as paravertebral injection. You can get a fairly good spread by injecting your local anesthetic not too far lateral, not too far medial, if that's what you can understand. We've described this in this article where we've used it for surgical anesthesia in primary breast cancer surgery, and we will discuss our technique and how you can use it consistently and reliably for a surgical anesthesia in patients undergoing breast cancer surgery in the next webinar. This is just to illustrate to you how the process is performed. We mark out the levels. This we do it on a consistent basis. We identify them using ultrasound and then perform the injections. Well, we started off initially performing 6 injections. Today it is our practice to perform alternate injections from T1, from T2, T4, and T6. So stay tuned, and we will discuss more about this in the next webinar. What I would like to share with you is that this is a review that we have completed under this clinical trial registration. We reviewed our work over a number of years where we had performed paravertebral injections, about 1,400 injections in these 430 patients undergoing breast cancer surgery. And you can see that the pleural puncture using this technique was 0. Now, this is again a word of caution is that this is we are very well-oiled unit as far as performing these injections, and they were all supervised injections performed by fellows or in regional anesthesia in our institutions. So pleural puncture again is very, very rare in centers that do them on a regular basis. The paralaminar technique has been described as a novel technique in recent times by a group from Japan. But is it really novel? I think that I often believe that you often say it's novel because maybe you haven't looked hard enough. Actually, this has been described, the technique of injecting paralaminarly in this study by Dr. Lewitt and Dr. Morrigal and the group in this cadaver study. It's also been described by Dr. Gautier in this review by Credit in their group. In fact, in 1952, Shaw described this medial approach for paravertebral somatic nerve block, which actually didn't receive a lot of good advertisement at the time because of many cases of total spinal anesthesia, and indeed in the ages of some local anesthetic injection, patient also developed Brown-Séquard paralysis. So this medial injection was actually discontinued, and it was not favored because of the following reasons that I just alluded to. But it basically involves contacting the lamina or the transverse articular process and then sliding the needle laterally when you are doing it with landmark and then performing the injection. The paralaminar technique uses ultrasound, but it is again, I believe they describe this as a laminar cliff, but as I mentioned to you, anatomically, it is indeed the inferior articular process, and they insert the needle almost from the medial aspect of the transducer, and they advance it just like you'd normally do for a traditional landmark-based technique, anterior-posteriorly. And because these are microconvex transducers with the phased array movement of the ultrasound beam, the advancing needle can be visualized and produces the effect that you normally see. Now, what about the mechanism of action by these various techniques? Okay, we are performing the injection into this wedge-shaped paravertebral space. An injection performed into the paravertebral space may remain localized at the site of injection, or it may spread to the intercostal space, the epidural space, and via the prevertebral route, it can also spread to the contralateral side. Because the paravertebral space actually communicate with the contiguous spaces, it can also spread via the paravertebral spaces to the contiguous spaces and thereby produce the segmental ipsilateral, somatic, and sympathetic nerve blockade that it produces. As you can see here, this is a CT performed in an individual having a liver tumor ablated under a paravertebral anesthesia. You can see here the loss of resistance was used, but I found it very intriguing because you can see now the air has become a contrast to show you how it has spread to the retrolamina area here. It has also spread to the epidural space. You can see here it's a small fraction of the total injectate, and it also spreads to the paravertebral space and via the prevertebral route to the contralateral side, including where the sympathetic ganglia would be located and the intercostal space. And if you look at it in a 3D, in a reconstructed image, you can see the segmental spread cranially and caudally. While most of the literature is based on the anatomic landmark-based technique, today there is data emerging about the ultrasound-guided technique. Before we go to the ultrasound, I think it's important to understand what happens when you perform an injection into the paravertebral space, be it is with landmark-based techniques. As illustrated by Dr. Chima and Dr. Richardson many years ago, an injection of 15 mils of 0.5% bupivacaine in these patients who underwent chronic pain procedures, it produces a mean dermatomal spread of about 4 to 5 dermatomes. But ladies and gentlemen, I'd like you to look at the range. It varies from 1 to 8. The sympathetic blockade, as assessed by thermographic imaging, was usually wider than the somatic blockade. And the ipsilateral sympathetic blockade did not result in postural changes in blood pressure in these awake individuals. The segmental spread of anesthesia. This is a collection of radiographs that I have pulled out from my archive, and you can see here this is the typical cloud-like spread that Professor Lundquist described many years ago. And this is the typical longitudinal spread that you see. But what you will see as we look more around it, a single 10 mil injection of local anesthetic mixed with contrast via catheter placed at T4, T5 level in patients undergoing thoracotomy produces a wide variability of spread at a single level. So what are the factors that affect the spread of local anesthetic? As I've shown you that the sensory spread can be quite variable. There's a tendency for more caudal spread of the dermatomal anesthesia, but age, gender, weight, height, dose or volume of local anesthetic does not improve the segmental spread of anesthesia, particularly with a single level injection. In fact, Chima and the group all demonstrated that injections in the same patients 2 weeks apart produce different pattern of sensory spread. As shown in this graph you can see here, if you increase the dose, there is poor correlation with the number of blocked segments. So increasing the dose would not improve your segmental spread. Increase the volume would also not improve the number of dermatomal segments blocked by this paravertebral injection. In fact, drugs like bupivacaine have a fairly slow onset to the peak effect. It takes about 40 minutes in 95% of individuals. Zohra Naja and her colleagues, including Professor Lundquist as part of our group here, demonstrated a few years later that multiple injections are indeed more reliable in producing not only clinical but also radiological spread of the drug. So if you are intending or you intend to produce multidermatomal anesthesia on a consistent basis, then you need to perform multiple injections. What I mean by that is if you're doing it for anesthesia on a Monday as well as on a Friday, then you need to do multiple injections. But if you're doing it for analgesia, then on Monday you may be lucky to have a very wide spread, and maybe on the next patient on a Monday you may not be so lucky. Okay, what about ultrasound guidance? Does it produce the same effect? Or there are certain differences in our sensory sympathetic blockade. This is a study by Dr. Patnaik and their group who used ultrasound-guided paravertebral blocks and compared them with landmark techniques in patients undergoing surgical anesthesia for major breast cancer surgery. They found that they injected 5 mils at each levels, and they performed the injections from T1 to T6 in 2 groups of patients. Total sample size was 72. And they compared the success of producing surgical anesthesia. The surgical rate of the success of surgical anesthesia was greater in the ultrasound group compared to the landmark group, and more dermatomes were blocked in the ultrasound group compared to the landmark groups. There was also less sparing of the T2 and T3 dermatomes in the ultrasound group. This is showing you the difference in the sparing of the T2 and T3 dermatomes. As you know, in breasts, when you do it for primary breast cancer surgery, T2, 3T are integral to providing the anesthesia. Also, postoperative visual analog pain scores at rest and movement was significantly lower in the ultrasound group compared to the landmark group. Finally, I'd like to show you in this paper by the same group that when you looked at the requirement of rescue analgesia in these patients who are undergoing these paravertebral blocks for surgical anesthesia, the patients who received the ultrasound group required less rescue, and the number of patients required less. But I'd like you to note here that indeed 80% of patients, even with the ultrasound guided, required rescue analgesia, whereas 60% in the landmark group required. While there was a apparent statistical difference, but again, it begs the question: is multi-level paravertebral block adequate for surgical anesthesia on its own? We will discuss more about this next. So this is another study from Greece, who performed intercostal injections with comparing transverse to the sagittal approach. They found that both approaches produced about 80-90% paravertebral spread, and there were no differences whether you used one or the other. But the word of caution is that this is a cadaver study with a very small sample size. Again, I have described this earlier. This is a study by Dr. Marhofer and the group. They use a transverse scan with outer plane needle insertion, like a traditional paravertebral landmark-based technique. And you can see here, this actually reflects the landmark-based data that I already presented to you. They are the sensory spread is quite variable in these volunteers, and the radiological spread was much narrower. Dr. Upal and Dr. Santakupam and the group from London, Ontario at the time, they compared single injection to multiple injection, 3 injections, using 25 mils of local anesthetic. And you can see here that they described that there were no differences in the segmental spread of anesthesia between the single or the multiple injections. So the ultrasound, there were no difference in sensory spread, but the single injection took less time. So they suggest that single injection may be desirable. I think the bottom line to this data is that these were used for analgesia and in combination with general anesthesia. So that's very valid. But if you are going to use it for surgical anesthesia, and if you see that the number of patients who had sparing of one of the other dermatomes in this cohort of patients, then one might wonder whether a single injection would be effective on a regular basis. Nevertheless, this needs to be validated in future studies. Nielsen and Dr. Morrigal and the group in this study compared single injection erector spinae block with multiple injection costotransverse block, which is one of those intertransverse injection techniques. And they found that the spread within the paravertebral space with the multiple injection paravertebral injection was greater than a single injection. Also, epidural spread was greater with the multiple injection when compared to a single injection. Seidel and their group performed this cadaver study where they looked at the spread of dye by varying the technique, volume, and volume of injection, and they demonstrated the higher the volume, the greater number of dermatomes would be affected, and also epidural is more common with medial injection techniques. As Dr. Taketa and the group from Japan has shown with the paralaminar technique, if you use a medial injection technique, which offers a greater dermatomal spread in these cadaver models compared to an intercostal approach that similar to the one described by Dr. Shibata. Again, in their study, this study report in the ACTA Anesthesia Scandinavica showed that a medial injection with the paralaminar approach produced better dermatomal spread, reduced IV PCA consumption, reduced pain scores in patients undergoing thoracotomy. So it appears that a medial injection would be desirable when you're doing paravertebral injections in terms of sensory blockade, the pain relief, and the rescue analgesic requirements that are illustrated in these shots. Finally, Fuji and their group compared transverse versus the sagittal approach for catheter placement, and they compared them in a cohort of 60 individuals, and they found that catheter placement was, whether using the sagittal or the transverse approach, was very similar. I'd like you to note here that with the sagittal approach, 2 catheters were placed within the thoracic cage, and one of them was within the epidural space in the transverse group. Visual analog space scores in these 2 cohorts were also very similar. So what are my conclusions based on this available literature? One is that there are several ultrasound-guided techniques described today, but there are no optimal techniques. Success of paravertebral block is superior with ultrasound guidance than anatomic landmark techniques. A medial injection technique produces greater epidural spread, a wider segmental spread of anesthesia. The analgesic efficacy, as illustrated in the patients undergoing thoracotomy, is also superior. So it may be desirable to perform the injection closer to the medial aspect of the paravertebral space. Large volume injections produces wider segmental spread of anesthesia. This is in contrast to what we saw with single injection landmark-based techniques. This is probably because we are placing the needle now under direct vision and under direct ultrasound guidance. Single versus multiple injection, it depends whether you're using it for analgesia or anesthesia. My opinion is that if you're using it for anesthesia, the multiple injection is desirable. But having said that, I think the study by Dr. Opal and the group about single and multiple injection needs validation in future clinical studies. Pleural puncture is rare, but can occur with ultrasound-guided thoracic paravertebral blocks. The new anatomical data that Dr. Yang and colleagues have presented has truly opened up new avenues for future research, and these need clinical evaluation and clinical validation. I thank you for your attention. Now, before we have a short break, I'd like to welcome Dr. Yang, if he's still around, Dr. Barrington, and to join us for any questions that you may, our registrants may have. Okay. Dr. Wong, Rossini Wong is our moderator. She's been looking through the chat to see what questions you've been posing. So, Rossini, do we have any questions for Michael or me or Dr. Yang?
Yeah, thank you all the speakers for the great presentation. So we've got several questions from the Q&A boxes. There's one for Dr. Barrington from Dr. Mohammed Beshrahil. Asking, so for spine surgery, would you recommend retrolaminar block instead of erector spinae block?
That's a big question. And, you know, spinal surgery is so variable. Spinal surgery, there's so many different variants of spinal surgery. I don't have a strong recommendation for that. I'm not aware of any definitive studies. I'd be open to hear other people's viewpoints on that.
Mm-hmm. Any other speakers have any viewpoints for this question?
Sorry, I was in the dark for a little while this is going on. I gathered the question was whether we can use retrolaminar as opposed to ESP.
Yes, correct.
For spine surgery.
That's the question.
I'm not aware of any data that has directly compared one with the other, but the anatomical literature and what even Dr. Barrington presented, that the retrolamina produces more a longitudinal spread consistently within the area of the lamina and the paralamina area. And if your requirement is in the along the both sides of the midline, then maybe retrolaminar is a good choice.
Okay. Thank you. Next question is, how low concentration of local anesthetic can be used for ESP?
I can see you, PA.
Hello.
Don't go away.
Hello, I will just optimize.
Yes, Michael, can you answer that question?
To me, no. I think you're a little bit confounded by the dosage of local anesthetic. So therefore, you know, whether you're doing bilateral or unilateral, but typically I think you need something around the concentration of 0.5% or 0.375% ropivacaine to load it up. But then after that, I think with the catheter technique, you're really committed to using a dilute concentration, something like ropivacaine 0.2 and giving a larger volume intermittently.
Yavuz, would you like to add a few words of
yes,
wisdom?
I think, thank you, Manoj. Great discussions and great lectures, and greetings to all our friends and colleagues from all over the world. Most of the time, different concentrations have been used for ESPB, but most of them, the ones also we are using is 0.25% bupivacaine. I think that's equivalent to 0.375 ropi or levobupivacaine.
Thank you. Question from Professor Karmakar from Dr. Lindsay. So she's impressed by your amazing research on the spinal area and would like to know whether you have any consideration of research on adult caudal block.
Thank you for the comment and for your compliments, but I rarely do caudal epidurals in adults. And I think there are some investigators doing this in the chronic pain field. So that's all I can say for now.
Okay, thank you. A question from...
Did you have a question? Professor Lundquist, did you have a question?
No, I was just trying to make a comment for the question about spine surgery, about
Yes.
the retrolaminar, because the surgeons will open up this area while they're performing the surgery. So I think it might be something that you need to discuss with your surgical colleagues if you will distort the anatomy or create hemorrhage or something like that. So I don't think that, although it's theoretically a place where the ESP block might work, is for back surgery, I don't think that the surgeons might be so interested because it's going to distort their field of surgery. That's my kind of 2 cents on that.
Thank
Okay,
you.
any other question, Rossini?
A question from Dr. Abdulazim asking, is serrated anterior block is superior than erector spinae plane block? I guess after all the presentations about.
That's not the focus of our discussion today, but I think Dr. Gurkan has done some work in this area, so I would like him to add a comment on this.
Thank you. ESPB has been shown to be superior to the serratus plane blocks, and I think I have a slide on it.
Okay.
Okay, it's coming up. And these are related to patients undergoing breast surgery or spine surgery?
They didn't.
Breast surgery, sorry.
Right. Okay, we'll have an interesting discussion later.
Describe catheter placement.
Are that all the questions for now?
An anonymous attendee would like you to describe continuous catheter placement technique in transverse articular process approach.
Okay. The technique is just similar to placing your single injection. You place the needle close to the lateral aspect of the paravertebral space with obviously a two-he needle system. And then you thread a catheter through that. But remember that you mustn't advance excessive lengths of catheter because it could find its way into the epidural space. And more importantly, it may override the vertebral body. This would not be very desirable for efficacy. So today, when I do place a catheter for the thoracic paravertebral, I would recommend you should advance maybe 2-3 centimeters at the most, and then withdraw the needle. Now, coming to this question, as the years have gone by, I'm doing less and less of catheters for these thoracotomy patients for two reasons. One is we have good multimodal analgesia post-operative and perioperatively. Second is we perform multi-level injections for our thoracotomy patients. Say we do T3, T5, T7, 3 injections with about 25 mils of 0.5% bupivacaine, whatever you use. Most of our surgeries today, 80% of them are video-assisted thoracoscopic surgery. If it is completed with the video-assisted thoracoscopic surgery, then we don't place a catheter. But if the patient, in about 10-15%, if it requires a thoracotomy, and mind you, they are no longer these days the massive posterior lateral thoracotomies we used to see during our days. They are usually mini thoracotomies, and we get the surgeons to place the catheters under direct vision. So we use the surgical dissection to create a retropleural space, and through which a two-he needle is inserted, and then the catheter is placed. And these techniques have been described in the literature. So this has become our go-to for if patients undergo thoracic surgery, require thoracotomy, where the catheter placement. And indeed, some of the stalwarts of post-thoracotomy analgesia with paravertebral blocks like the late Professor Sabanathan and Dr. Richardson, they described these techniques many, many years ago, including Dr. Beresford. They placed the catheter under direct vision, surgically placed, and it's shown that it produces very consistent cephalocordite spread of the contrast and the local anesthetic, and produces very effective analgesia as part of a multimodal analgesic regime, which they described then as balanced analgesia. However, if you give a patient just a paravertebral block catheter and you don't give them any other co-analgesics, I think you'll be doing them a disfavor. So it has to be used as part of a multimodal analgesia, and which often also includes opioids. Okay, this is all I might say to that question.
Okay, one more last questions for Professor Karmakar again. Could the out-of-plane approach to the thoracic paravertebral block injure the ventral branch of the spine, spinal nerves?
The ventral rami of the spinal nerve?
Yeah, I think that's
the intercostal nerve.
Yes.
I think it is always there's nothing not possible. I think it is possible. But when you're doing the outer plane approach, it definitely places the needle probably more on the medial aspect of the paravertebral space in compared to the intercostal or the transverse process and articular process windows. But again, there are no reported long-term effects of such injuries being described in the literature or that we have experienced in our clinical practice. But that said, those of us who perform paravertebral injection, it is not uncommon at the start of your injection, you'll often find patients will report some distension paresthesia. This usually goes away in a few seconds, but you will find that as you start your injection and you start distending the space, the patients will often report paresthesia. This, I believe, is because of the distension of the space and probably stretching of some of the nerve rootlets. Now, Professor Nunn, if many of you know, described many in the 1980s that in fact the intercostal nerve, after it emerges from the intervertebral foramina, and in fact this is also seen in Dr. Yang's slides, that once it comes off the medial slit, it actually not a single nerve, it's into multiple rootlets. So these small nerves can distend and produce that paresthesia that are very common. In fact, we see it in about 80% of our patients. But they don't go on to develop long-term sequelae, neurological sequelae. This is all I might say for now.
Okay. I've just spotted one more question in the chat box, not the Q&A box. A question for Dr. Barrington. Dr. Lee from Melbourne would like to ask, so would you use ESP for anterior fracture ribs instead of paravertebral block?
Michael, can you unmute yourself?
I beg your pardon. I would use a thoracic paravertebral block for anterior ribs, fractured ribs. Yeah.
Okay, I think that's all the questions we have now.
Okay. Thank you, Rossini. Thank you, Michael. Thank you, Dr. Yang. And thank you, Yavuz, for joining in. We have, for you participants, we're going to have a short break, 15 minutes. You go and have your favorite beverage, as I always say. We'll commence the proceedings again, and then we will look into the clinical effects and clinical applications of these various thoracic blocks. So until then, bye for now. Hello, everybody. Welcome back. So I hope the preceding session set the tone or set the stage for what we're going to discuss now. We're going to now have three very well-known individuals. I introduced them to you earlier, and we're going to be doing some discussion relating to the clinical applications of thoracic epidural first, then thoracic paravertebral, and then erector spinae. And then we'll have a Q&A once again. So the first speaker after this break is going to be Professor Boezaart. And Professor Boezaart is with us, but he has very kindly sent us a recorded lecture in order to avoid some of the difficulties that you can encounter sometime with poor bandwidth. So we're going to now have Professor Boezaart with his lecture on thoracic epidural anesthesia and analgesia. Could be the technique of choice for unilateral pain or surgical procedures in the thorax, particularly related to multiple fracture ribs, primary breast cancer surgery, and video-assisted thoracoscopic surgery and thoracotomy.
My name is Andre Boezaart, originally from the pain service of the University of Florida, and now working for Lumina Health Pain Medicine Collaborative. I have no applicable disclosures, and again I thank Professor Karmakar and the organizing committee for inviting me to participate in this debate section. The question is whether epidural anesthesia, fascial plane blocks, or thoracic paravertebral blocks are the most appropriate for the post-op analgesia of thoracic surgery. Obviously, as everybody knows, there is no one-size-fits-all to answer this question, and every one of these regional anesthesia modalities has its own list of pros and cons. My task is to focus on thoracic epidural anesthesia and analgesia, and that it should be the technique of choice for unilateral pain or surgical procedures in the thoracic area. Thoracic epidurals used to be very popular in the 1980s and 90s, but now has fallen from popularity among surgeons because they claim that the thoracic epidurals don't work, and it introduces complexity for the care team because of the hypotension that it causes. But as we know, for regional anesthesia to be successful, you need 5 things. You need the correct indication for the block. You need to block the correct nerves. And although this sounds simplistic, from real-life situations, we have all seen actual cases of lumbar epidurals that were performed for laparotomy or thoracotomy, and we all know that these are pretty useless. Number 3 is the use of the correct technique. Number 4 is the correct equipment. For example, thin, sharp needles around the dura is dangerous. Number 5, we have to have the correct recipient of the block, and this should not be the PACU nurse, the surgeon, the institution, your partners. It can only be the patient. So let us start with the correct indications. To answer the question of the correct indication, you have to ask yourself, what am I doing? Why am I doing it? Who am I doing it for? What are the risks and what are the benefits? You first have to convince yourself of these questions and then the patient, which right there gives you 100% informed consent. Let us look at a few examples of this. I'm asking myself, what am I doing? I'm doing a thoracic epidural block. Why am I doing that? I'm doing it for unilateral minor breast surgery. Who am I doing it for? I'm doing it on the surgeon's request. What are the risks? We all know the risks of thoracic epidurals. And what are the benefits? We have good pain control. But this is the wrong indication. Unilateral thoracic paravertebral block is a better choice than thoracic epidural for this specific indication, and no block at all may even be a better choice. Another indication, what am I doing? I'm doing a thoracic epidural block for unilateral major breast surgery. Who am I doing it for? The surgeon's request. What are the risks? All the risks associated with thoracic epidural block. And what are the benefits? That's obviously good pain relief. Again, this is the wrong indication because unilateral thoracic paravertebral block is most likely a much better choice. There are no visceral receptors in the breast. What am I doing? I'm doing a continuous thoracic paravertebral block or a continuous erector spinae plane block. I'm doing this for a thoracotomy involving the lung and the visceral pleura. Who am I doing it for? Again, the surgeon's request. What are the risks? Much less than thoracic epidural analgesia or anesthesia, we may argue, although I don't agree with that. What are the benefits? Great somatic analgesia. Again, wrong indications. We need visceral and somatic block for this indication because we are involving the visceral pleura. The same goes for laparotomy, where we have to involve visceral pain, and a thoracic paravertebral block or a erector spinae plane block does not block pain coming from the viscera. I'm doing a thoracic epidural block. Why am I doing it? I'm doing it for bilateral lung transplant, again surgeon's request, and again all the risks of thoracic epidural block. What are the benefits? Somatic and visceral pain, but it's again the wrong indication because the lung and visceral pleura had been denervated. The lung has been taken out, denervated, and a brand new lung has been transplanted. Visceral block is thus not needed, and bilateral thoracic paravertebral block is a better choice. What am I doing? A thoracic epidural block for multiple rib fractures with no pleural involvement. And this multiple rib fractures can be unilateral or bilateral, again surgeon's request, and again all the risks associated with thoracic epidural block. What are the benefits? Great visceral and somatic analgesia. Again, the wrong indication because we block the visceral and the somatic pain, but there is no visceral pain. Continuous thoracic paravertebral block is again a much better choice in this scenario. What am I doing? Again, a thoracic epidural block, multiple rib fractures, extensive parietal and visceral pleura involvement, bilateral or unilateral. Again, the surgeon's request. Again, all the epidural risks, and we have great visceral and somatic analgesia. Now, this is a great indication because we block the visceral and the somatic pain with the thoracic epidural block. So let's move on to blocking the correct nerves. Here we have to go and have a look at Anatomy 201. How does thoracic pain get to the brain? Somatic pain from the thoracic area and the abdomen gets to the spinal cord and brain via the intercostal nerves. These are somatic nerves. Now, how does visceral pain get to the brain from the abdomen? Visceral pain from the abdomen goes via the preaortic ganglia and splanchnic nerves to nerves associated with the sympathetic trunk. We used to think that these nerves associated with the sympathetic trunks are sympathetic nerves, but it has been shown lately that they are not sympathetic nerves, they are just associated with the sympathetic trunk. So how does visceral pain get to the brain from the thoracic area? And again, this pain of the thoracic viscera gets to the brain via the sympathetic ganglia, again with nerves associated with the sympathetic nerves, not via the sympathetic nerves themselves. Viscera originate embryologically from midline structures. It thus has bilateral innervation. Visceral pain has incorrectly been assumed to be sympathetic because afferent fibers are anatomically associated with the sympathetic division of the autonomic nervous system. Visceral pain is also perceived as more unpleasant than somatic pain and found to be more fear-evoking than somatic pain. Parietal peritoneum and most likely parietal pleura has somatic and visceral afferent innervation, as shown by this paper from Pleura and Peritoneum 2017. As can be seen from this same publication, visceral peritoneum and most likely visceral pleura has no innervation, but submesothelial tissue is innervated by the parasympathetic nerves, in other words the vagus nerves, and nerves associated with the sympathetic nerves. So, cell bodies of the spinal afferent nerves that are anatomically associated with the sympathetic nerves can look like this animation. The paravertebral ganglion is depicted in yellow here. The preganglionic sympathetic nerves in light blue synapse in intermediate lateral nucleus of the spinal cord and leaves the spine via the anterior spinal root to enter the paravertebral sympathetic ganglion. Incoming splanchnic visceral branches, the white lines on this illustration, traverse the sympathetic ganglion en route to the dorsal root ganglion and spinal cord. They may branch and send off collaterals that synapse with the prevertebral ganglion neurons. It is also becoming increasingly evident that bone pain and ischemic pain behave more like visceral pain than somatic pain. Bone pain, such as from rib fractures, are most likely also visceral pain, but we don't know this for sure yet. What we do know is that the parietal pleura also has visceral innervation that travel to the brain via the nerves associated with the sympathetic nerves. A recent important paper by Vahal et al. Demonstrated that ischemic pain and visceral pain have a shared anatomic conduction pathway, namely sympathetically mediated perivascular A delta and C fibers. Ischemic pain should thus also be viewed as a form of visceral pain. So requirement number 3 and 4 for effective regional anesthesia, we need to use the correct technique and we also need to use the correct equipment to make it work. In 1995, there was a big push to the revitalization of thoracic paravertebral block. The question now is if thoracic epidural block is now where thoracic paravertebral block was in 1995. In 1979, Easton and Wyatt quoted from the then current literature and stated that thoracic paravertebral block is now of more interest to historians than to practical anesthesiologists, and they called for its reappraisal. In 2001, Professor Longquist called thoracic paravertebral block the sleeping beauty. My colleagues and I from the University of Iowa at the time also visited this in an editorial called Sleeping Beauty or Big Bad Wolf, and we wrote a paper on continuous thoracic paravertebral block for major breast surgery. Thoracic paravertebral block was called the Big Bad Wolf because in 1979 it was argued that there was a lack of absolute indications for thoracic paravertebral block. There was a familiarity with thoracic epidural block and the omnipresence of adverse effects at that stage, pneumothorax and subarachnoid injection. Are we now with thoracic epidural analgesia or anesthesia where thoracic paravertebral block was in 1995? Is it now time to revitalize the thoracic epidural block? And now in 2021, the thoracic epidural block is viewed as the big bad wolf because of exactly the same reasons. Lack of understood indications for thoracic epidural block, relative familiarity with thoracic paravertebral block, and the omnipresence of adverse effects, namely mainly hypotension and block failure. It was argued in 2002 that adding nerve stimulation to paravertebral blocks make them safer, and now obviously ultrasound makes it even more safe. The epidural failure rate is anything between 15 and 30%. Also, unilateral epidural block is as high as 15%. And these are related to epidural blood vessel, the plica mediana dorsalis, and anterior Hoffman ligaments. We have recently argued that unilateral epidural can also be related to prelaminar fibrous bodies. These bodies were not known to us prior to the work that we have done in 2018. Recently also, the spacer fucada has been shown to cause a false loss of resistance during attempted epidural block. The other causes of failure is false loss of resistance to air, lack of advanced skills, and lack of a dedicated acute pain service. All of these can be fixed with realization of the appropriate indications, the requirement of blocking visceral pain, and then revivification of the skill set that sadly has been neglected over the past 20 or so years. And then it can also be fixed by just adding a nerve stimulator to the epidural catheter, as we've done for thoracic paravertebral block in 2002 and 3. And then all can be fixed by removing the chief adverse effect. There has been a lot of work over the past 20 or so years to add nerve stimulation to the catheters, and progress has been hampered by a host of negative press. All stimulating catheter complications were associated with the StimuCath and its open coils and flimsy material. This scared practitioners in using stimulating catheters. So everybody was scared of putting StimuCaths into the epidural space to ensure correct catheter placement. Lately, there are a number of catheters that don't suffer these shortcomings of the StimuCath. For instance, the Payunk stimulating catheter and the UltraCath made by Arrow. These catheters have the same material as the epidural catheters made by the same companies, and it has a closed tip made of polymers. Other ways of ensuring correct epidural catheter placement is waveform analysis, fluoroscopy, which is cumbersome, ultrasound, and then there's lately a new technique where a GPS needle tracking system is used. Unfortunately, although very promising, does not tell us where the catheter goes. There is no free lunch, so unfortunately we cannot block the nerves associated with the sympathetics without also blocking the sympathetic nerves themselves. there is a price associated with blocking the nerves associated with the sympathetic nerves, and that is hypotension. So how do we deal with that hypotension? The obvious answer is to treat it. And how do we treat it? First, explain the mechanism of this hypotension so that the surgeons and, unfortunately, some anesthesiologists actually understand it. Then secondly, to remove the cause of the hypotension, which is usually hypovolemia. Thirdly, increase the cardiac output, because on a high thoracic epidural, the sympathetic nerves to the heart can be blocked, and also the sympathetic nerves to the adrenals can be blocked, and that can cause a decrease in cardiac outputs. So we have to increase the cardiac output, and the best way to do this is with a low-dose beta-1 agonist. But we do not treat hypotension of thoracic epidural with pain or any other alpha agonist, as we so often see where the epidural is turned off in cases of hypotension. Intralipid also now is receiving favorable attention for increasing the cardiac output, and in our practice this is now routinely given for patients suffering hypotension following thoracic epidural block. Finally, the fifth requirement for effective regional anesthesia is that we have to have the correct recipient. In conclusion, if we thus treat the patient, we do not use thoracic epidural block when uni or bilateral somatic pain is involved, only when there is also visceral pain. So we use it for the correct indication. We figure out how to revive the necessary skill set for thoracic epidural in our institutions. We use appropriate equipment, and here I would strongly advise the use of nerve stimulators applied to the catheter. We also have to figure out how to manage hypotension, and here again I strongly advise normovolemia, beta-1 agonist, and lipid emulsion intralipid, and certainly not pain. Lastly, we need an active acute pain service following the thoracic epidural blocks. Then, if we do the above, then sure, thoracic epidural anesthesia and analgesia should be the technique of choice for uni or bilateral pain or surgical procedure in the thoracic area or abdomen where visceral and somatic pain is concerned. Again, I thank Professor Karmakar and his team for inviting me to present this part of the argument. I thank you for your very kind attention.
Thank you, Andre. Thank you, Professor Boezaart, for setting the stage with your arguments about use of thoracic epidurals. Now it gives me great pleasure to invite Professor Per-Arne Lundqvist, all the way from Stockholm. He's been very patiently waiting. And I've already introduced Professor Lundqvist to you. He's a great champion of regional anesthesia. And take it away, Professor Lundqvist.
First of all, thank you very much, Manoj, and the rest of the organizing committee for allowing me to be part of this fantastic webinar. I want to thank you, and I would also like to thank all the other speakers for a fantastically informative and somewhat intriguing lectures, I would say. So I have been invited to speak in favor of the thoracic paravertebral block in the clinical context, and I will shamelessly do so. This is about unilateral things, but I would just like to remind you that you can, in fact, use bilateral thoracic paravertebral blocks, as Dr. Boezaart told you in the previous lecture. And if you want to learn more about that, you can look at this review article in British Journal of Anesthesia. Second, I have a disclaimer, and that is that I'm a healthy skeptic to many of the new fashion plain blocks. And you can read the conclusion there. And together with Manoj, I have published 2 papers, an editorial and also a daring discourse, where I discuss the pros and cons of regular peripheral nerve blocks and these new fascial plane blocks. So you should bear that in mind. Okay, we will start with a little bit of history, and the first wave of enthusiasm when it comes to paravertebral blocks was in the early 1900s, where Hugo Selheim and Arthur Levin in Germany first discovered this paravertebral block technique, and it is said to be first used for surgical anesthesia in 1919 by Capis. So it was very popular during the tuberculosis era, where you have thoracoplasties and that kind of thoracic surgery, but as other anesthetic techniques evolved, it went into this sleeping beauty period, as we heard about. And Dr. Boezaart already has mentioned this seminal paper by Eason and Wyatt calling for a reappraisal of the technique in 1979. And then there's a few of us, the disciples, that have tried to spread the gospels through the years. And I would also like to remind you that it is now the 25th anniversary of this very illustrious medical society, the International Paravertebral Society, that unfortunately rapidly became the smallest medical society in the world because Sebenathan unfortunately had a coronary and died. So if you want to join, please let me know. So why did I bother you with history? And that is to tell you that it's more than 100 years old, this blocking technique, so it has passed the test of time. And it's an older technique even compared to epidurals. And as Dr. Boezaart kindly said, it's now well established and widely practiced. So I think that there is a big good reason for you to use this. The other thing that I would like to do is puncturing the pneumothorax balloon. You heard previously Manoj Karmakar telling you about the frequency of inadvertent pleural punctures and pneumothoraces. And I have myself been part of two studies looking at this. The first one with the landmark-based loss of resistance technique. And then we found a 0.5% incidence. We also looked at the nerve stimulator guided technique together with the Sonoanatomy in Lebanon, and we found the same, a 0.5% incidence, with very, very rare need of putting in a chest tube and using suction. So that is a very rare complication. And as you heard from Manoj, he has used the ultrasound-guided techniques in thousands of patients, and so also the Danish group with Nielsen, and there is no pneumothorax. So I think that there is, we should stop talking about this as some sort of threshold to use paravertebral blocks, especially when we have ultrasound guidance. Okay, let's go to the core topic of the lecture, and that is the unilateral various procedures, and one is the posterolateral thoracotomy. And to save myself time and energy, I went to the European Society of Renal Anesthesia, where they have these procedure-specific postoperative pain management guidelines, the prospect. And the prospect guidelines for this type of surgical intervention, then they suggest that the paravertebral block and continuous infusion is the first-hand choice for good analgesia, but also lower complication rate, as Dr. Boezaart alluded to in the previous talk. And this is a grade of recommendation A. Also, the use of thoracic epidurals are good, especially if you use epidural opioids. So, but paravertebral blocks is the first recommendation of the prospect group. And what type of complications do you see? Well, you do see an increased number of pulmonary complications. You also see increased postoperative nausea and vomiting. You see an increased rate of urinary retention, but also, as we heard in the previous lecture, there is this issue of blood pressure and hemodynamic stability. And that is then in this prospective randomized controlled trial by the Amir Hadzic group, showing that you have less complications, hemodynamic complications, and you need smaller volumes of colloids and vasopressors. Also, Richardson and Sebenathan and others quite some time ago looked at what happens to post-operative thoracotomy neuralgia. And they looked at 1,000 consecutive thoracotomies in their practice in Bradford, and they could show that resecting a rib for access, then reducing the surgical trauma, and continuous paravertebral analgesia and non-steroidal anti-inflammatory drugs, in fact, could reduce this. So I think that paravertebral analgesia do have some specific characteristics that you can make use of. If you then go on to oncological breast surgery, I know that this will be discussed the next webinar session. And again, looking at the prospect recommendations that were published in Anesthesia last year, you can see that they obviously advocate the use of all these multimodal components, but also say that paravertebral block is recommended as the first choice region anesthetic technique. They go on and state that the pectoral nerve blocks may be of use and even local anesthetic infiltration. And since the prospect guidelines are based on a very thorough literature search and the more or less meta-analysis process, I think that these guidelines are very useful and adequate. As with looking at the thoracotomy patients, you can also have some nice preventive effects regarding long-term pain, as Cairo Lohman and co-workers have shown, where they could show that the women that had paravertebral block instead of morphine post-operatively for pain relief had reduced prevalence of pain symptoms at the 12-month follow-up. So again, you can maybe influence the risk of having chronic problems after your surgery if you use the paravertebral approach. If you then switch over from oncologic breast surgery to non-oncologic breast surgery, there has been two very nice recent prospective randomized trials from Ilfels group. And this first one, then published this year from Gabriel, could show that the serratus anterior plane block versus paravertebral nerve blocks in fact came out inferior. This was designed as a non-inferiority study, but in fact, as you can see in the conclusions, serratus blocks provide inferior analgesia compared with the paravertebral blocks. These are the results, and you can clearly see that the median pain scores in the recovery room are very low in the paravertebral group and substantially higher in the serratus anterior plane block. But something that caught my eye is that if you arrive in the recovery room or soon thereafter develop a pain score of 5 or more, then I would suggest that you have a failed block. And if you then agree with this definition, you can see that there are 5 out of 50 blocks in the paravertebral group, but there are 15 in the serratus anterior plane block that could then be defined as block failures, which is about 30%. So I think that kind of is something that you should bear in mind. Here is the other publication from the Ilfeld group by Swisher, who compared the Erector Spinae plane block with the paravertebral nerve block, also having 50 patients in each group, prospectively randomized. And they could again show, when it comes to pain scores and opioid consumption, that the paravertebrals are superior to the ISSPS blocks for post-operative analgesia after non-mastectomy breast surgery. So in these types of patients, the paravertebrals seem superior both to serratus anterior blocks and to the erector spinal plane blocks. If we look at, again, the same for the ESP versus the paravertebral blocks, you can see that most patients in the paravertebral block have zero pain in the postoperative pain unit and considerably higher median pain scores for the ESPB. And here you can see that it's even 4 times higher failure rate if you agree with this definition of failure in the ESPB group compared to the paravertebral group. Professor Karmakar commented on that thoracic surgery now is performed less invasively, and if you look at the thoracoscopic surgery, which has becoming more and more popular, this is a quite recent publication from this Turkish group that prospectively randomized have looked at erector spinae plane blocks versus intercostal blocks or paravertebral blocks. And what they did show in this study was that the dynamic pain scores were significantly lower if you use the paravertebral compared to ISSPS or intercostals at 24 hours. There was significantly lower morphine consumption during the first 24 hours, and the thoracic paravertebral block appeared to be preferable compared to the other techniques. So again, the paravertebrals are quite effective in this setting. If you then instead compare it to thoracic epidural analgesia, as we heard in the previous talk, the thoracic epidural is producing very good results. However, if you use a single injection paravertebral block, that led to the same similar patient satisfactions as if you use the thoracic epidural analgesia. And the authors conclude that at their institution, which is in Minnesota in the US, I think, that the single injection PVD is performed for most VATS cases owing to the shorter placement time and lower risk for serious adverse events. Then going over to this issue about multiple fractured ribs unilaterally, and Dr. Boezaart has already summarized that quite nicely for us, I would say. I tried to find some prospective randomized studies, and I did find this from Journal of Trauma from 2009, and that shows that both thoracic epidural and thoracic paravertebral block behaved more or less identical. As you can see in this figure, there is no difference between these two methods when it comes to morphine requirements, length of stay in the ICU or hospital stay. But as we all know, of course, there is a higher incidence of hypotension in the thoracic epidural group. Otherwise, they're completely comparable in this study. As many of you know, I don't like case reports or case series from a scientific point of view, but sometimes they can be quite entertaining. And I couldn't help but share this case report from military medicine with you. We all have residents, and this can be interesting to bring in your back pocket when you have some lazy resident around. This anesthesiology resident were out biking, crashed and had multiple rib fractures, and were of course unable to perform his clinical duties, which didn't work well in the military medicine environment. So he got single paravertebral nerve injections at T6, 7, 8, and 9, and got a catheter. And again, he was able to work, and he could take the catheter away after 18 days with no associated complications. This has, of course, no scientific merit at all, but it can just show you what the paravertebral catheter can do in the odd case. If you look at rib fractures in general, I have been unable to find any nice prospective randomized controlled trials, but there are two narrative reviews from our esteemed session chairman, Manoj, and in the one that is from 2011, his summary then is our preference tends to be the thoracic paravertebral approach, which I completely agree with. In a little bit later review from 2019, he's a little bit more cautious and says that it depends mainly on the available expertise and anatomical location of the fractures. And of course, if you have very, very posterior rib fracture, which is to me quite uncommon, I think that the ESP block, for example, could be effective for that, but anything in front of the mid-axillary line deserves some sort of other analgesic approach, being it a paravertebral or an epidural. I will end this talk on the same note and looking at traumatic rib fractures, but intravenous lidocaine is a quite interesting concept. And if you look at this study, published fairly recently in Regional Anesthesia and Pain Management, where they retrospectively compare thoracic epidurals with intravenous lidocaine, you can then see how they perform in this figure over here over 48 hours, and you can see that the epidural is performing slightly better, but that intravenous lidocaine is performing quite well, in fact. And in the situation where you don't have the possibility to offer the patient a thoracic epidural, then intravenous lidocaine may be very helpful to reduce the numeric pain scores, which I think is highly interesting. If we then just switch gears and look at the pharmacokinetics of lidocaine after bilateral ESP blocks that also were published recently, I was very surprised to see this pharmacokinetic profile of the ESPB lidocaine injection. This is the intravenous injection of 1 milligram per kilogram intravenously, and that we know provides quite decent analgesia and also have other favorable effects as reduced time of postoperative ileus if you have abdominal surgery. But if you look here at the profile of 3.5 milligrams per kilogram given in this bilateral ESPD, you can see that almost immediately, within 5 minutes, you have quite high concentrations than the intravenous injection. And you can also see here at the end that the terminal half-life is much slower than after the intravenous injection. So to come down to this point, if you follow this line, you will have an effect of this for some 8 or 10 hours. And these authors, who are then proponents of the ESP block, not as I am a skeptic, they conclude we propose the systemic analgesic effect of local anesthetics as a further piece of the puzzle to explain the analgesic effect of the ESP block. Well then, how can you get such a rapid absorption of the injected local anesthetic from the Erector spinae plane? And this was clearly shown by Ortero, which is a group from Argentina, I think, from South America. They injected dye in this Erector spinae plane in living pigs, and then soon thereafter they then euthanized the pigs and made dissections. And what they can see then is that within a couple of minutes, like 10 minutes, you have very, very highly stained lymph nodes, pre-aortic lymph nodes, but you have no staining here in the paravertebral space. So it is rapidly absorbed by the lymphatic system. So what happens here is that you will inject your local anesthetics here. It will get absorbed by the lymphatics, brought to the pre-aortic lymph nodes, and then go into the thoracic duct, and then go immediately into the superior vena cava. So it is very, very close to an intravenous injection. So that explains why you have such a rapid absorption and high initial concentrations of local anesthetic when you do an ESPB block. And I will, this is my next to last slide, and this is hot off the press from Regional Anesthesia and Pain Management, where they had a prospective randomized trial comparing a regular TAP block with the intravenous lidocaine for renal transplant recipients. And they were looking at 60 patients in each group. And what they could find was this study found no difference in pain scores or persistent opioid use between the groups. So lidocaine in non-inferior compared to tap blocks, which kind of tells me that the effect of tap blocks to a large extent is due to systemic absorption of lidocaine or whatever regional anesthetic you use. So that is the end of my talk, and thank you so much for listening.
Thank you, Pier, for the wonderful presentation. You surely did great justice to our paravertebral camp. Now, with the set stage for the last speaker of this evening or morning, for some of you in America, in South America, been waiting quite some time, and I've introduced Professor Gurkan to you earlier. Dr. Gurkan is going to now present to us why erector spinae pain block should be the technique of choice for unilateral thoracic pain. Take it away, Yavuz.
Thank you very much, Manoj, for the kind introduction. It's definitely a very interesting discussion. So I have learned a lot from our speakers and lecturers, and I hope that all the participants also enjoy equally with these talks and lectures. Okay, now I will be talking about ESPB and sorry. Okay, I will talk about ESPB, and I recommend that it should be the technique of choice for unilateral pain or surgical procedures for the thorax. Now, ESPB, I know we have been talking for now for hours, but I have to remind that it is a very simple technique, injecting local anesthetic just about transverse process and beneath the erector spinae muscle. And on the right side of the screen, you can see a cadaver, well, the skeleton actually, from a crocodile from Philippines. Transverse process really looks huge. So we have simply a very big target, very easy to catch. You cannot miss it, whether you use ultrasound or maybe for pain doctors, fluoroscopy, and so on. So it is a rather simple technique. But this technique, with this using this approach, we are actually very close to the spinal nerves and their dorsal and ventral rami. So this is a picture from the Nysora team on the left side. You can see the spinal nerve, dorsal, and the ventral ramus. Actual erector spinae plane block, it's a route of local anesthetic injection, very close to the neural structure. So it's not like exactly TEP block or pectoral blocks. This time we are very close to the neural, central neuroaxial structures, to the epidural space, and also to the spinal nerves themselves and their rami. There's been lots of explanations thanks to all the previous speakers. It's just a short review that different anatomical studies interestingly end up with different results, but at least, or quite many of them have found that epidural spread is possible with ESPB. Paravertebral spread is possible. Ventral rami, the great majority says the local anesthetic or dye goes to the ventral rami, and everyone agrees that at least the dorsal rami will be affected by ESPB. And right from the start, with Ferrero's contribution to the literature and to regional anesthesia field, ESPB has been used for both chronic pain, neuropathic pain, and for postoperative analgesia for thoracic surgery. So actually, Ferrero introduced ESPB right from the start for thoracic surgery or pain originating from the thorax from different sides. And it includes shoulder surgery, and it's a very good alternative if for some reason you cannot perform interscalene block, and then you can do ESPB and it will provide some analgesia without affecting the diaphragmatic excursion. It is good for thoracic surgery, whether it's done video assisted or open, for rib fractures, for breast surgery, obviously, and also for cardiac surgery. Now, for thoracic surgery, we have actually published several case reports, and we have conducted a few randomized controlled studies, and not all of them are published, not yet. But there are quite many papers suggesting that ESPB is good for thoracic surgery. And here ESPB has been compared to serratus plain block, and it has been shown for thoracoscopic surgery, and it has been shown to be superior to the serratus anterior plain block. Now, what about intercostal nerve? This time, ESPB has been compared to the intercostal nerve performed by the surgeon. And this is what happens in clinical reality. You may ask the surgeon that you're planning to do an ESPB for thoracic surgery, and he will say, don't worry, I will do the intercostal block. But what is the result? The result is that ESPB is superior to the intercostal nerve block, and it provides better patient satisfaction, better analgesia, and less respiratory muscle impairment. This time, ESPB has been compared to the intercostal nerve block, and you can see that this is a randomized study, and you can see that ESPB is superior to the intercostal nerve block. Now, this time, 59 patients, a large series. ESPB has been used for thoracic surgery, and the cases include minimally invasive robotic thoracoscopy, thoracotomy, rib plating, and non-operative reasons. And it has been shown that ESPB should be considered as part of ERAS and provide non-narcotic ways to control pain therapy. And it has been recommended to be clinically effective by a large group of researchers. And the only complications are catheter dislodgement problems or catheter problems, but otherwise no serious complication. Now, if we look at the breast tissue, which is most of the time unilateral, then we can see that this is the review from, this is the Kijay Chin's article about the anatomy. You will see that the anatomical innervation of breast tissue is so complicated. It gets nerves from neuroaxis, the spinal nerves, from brachial plexus, and from cervical plexus. And the same thing, Joanne makes a brief summary of breast tissue innervation, and it is a rather complicated innervation if you want to cover all aspects. Now, this is our study. We have performed ESPB. This is randomized study with control group, prospective study for breast surgery. And let's have a look at our conclusion. If you compare it to a control group, the total amount of opioid in Turkish population is 5 milligram if you perform ESPB for breast tissue in 24 hours. And this is, I would say, nothing. And if you don't perform a block, then the opioid consumption is much higher. Of course, the main issue, one of the main important questions that we have to answer, which block should we choose? Now that we have a large armamentarium of different regional anesthesia techniques, then we need comparative studies. Actually, we did this study. We compare ESPB versus thoracic paravertebral block, which is also one of our favorite blocks for, especially for thoracic area. And then what we found that ESPB and paravertebral block almost end up with almost equal analgesic consumption following surgery. So ESPB is quite similar to paravertebral, except that at postoperative first hour, paravertebral block group patients required less opioids, lower VAS scores, but otherwise they are almost identical. Now, there is a big question. What if we administer IV lidocaine, or if we inject lidocaine or any other local anesthetic just anywhere, but not at the level of the Erector Spinae plain block? Now, this time Gözenöksüz from Turkey has compared bilateral ESPB versus tumescent anesthesia done by the surgeons for postoperative analgesia in patients undergoing reduction mammoplasty. And what she found that ESPB is much, much superior to the tumescent analgesia, where you administer huge amount of local anesthetic into the tissues. Now, this is a common interest area, I know, for Manoj, for me, and for linguists also, and the other colleagues that deal with regional anesthesia. Paravertebral blocks have been so famous for awake surgery or breast surgery without general anesthesia. But this is a case series, 100 patients from Australia. Let's see how they have done it. The patient received IV fentanyl, 100 microgram. The patient received propofol infusion plus local anesthetic infiltration by the surgeon. And this is what paravertebral block is probably most famous. And now this time 30 patients reported from India, ESPB erector spinal plane block for breast surgery without general anesthesia. They performed the block at T4 level, 25 milliliter of 0.5% bupivacaine was administered, plus dexamethasone. And then they administered fentanyl, 1 microgram per kilogram, plus propofol infusion. I tell you, this is nothing different than the paravertebral block with the earlier publication. So it means it's actually, if you remember the anatomy slide, the breast tissue innervation is very complex, and neither paravertebral nor ESPB alone, without additional local anesthetic or propofol infusion, would be enough for the surgical anesthesia. So it is nothing like axillary block or infraclavicular block performed for hand surgery. None of these patients would require additional analgesics or additional propofol infusion for surgical anesthesia. Now, this is a review actually for breast and thoracic surgery, 14 studies. Maybe it gives us a better idea. More than 1,000 patients have been included. And the conclusion is that ESPB reduces opioid consumption, reduces pain scores, reduces postoperative nausea and vomiting, and it is not clinically worse than thoracic paravertebral. So ESPB is quite similar to thoracic paravertebral block in conclusion of these 14 studies and more than 1,000 patients. And the recommendation is that ESPB is a viable alternative to thoracic paravertebral block. Now, cardiac surgery is actually not our topic today, but just very brief comment. This study from Philip Macaire, a well-known friend of us, a regional anesthesiologist, he published that ESPB and is good for cardiac surgery. I will not go into details. And similar results from children, pediatric cardiac surgery. And now let's go to the unilateral surgery, because this time today we are talking about unilateral surgery. And this is unilateral, kind of, at least unilateral cardiac surgery. The surgical incision for mitral valve replacement is via mini thoracotomy. And they showed that ESPB was performed before induction of general anesthesia, 0.2 milliliter per kilogram, and 0.375% ropivacaine. And it is very effective for pain control. Mechanical ventilation times are shorter, and the time spent in ICU is shorter. So ESPB for mini thoracotomy cardiac patients is definitely clinically useful. Now, when it comes to rib fractures, this time 4 patients, the study also, the investigators also have a look at where the local anesthetic goes, but this has been already extensively discussed, so I will skip it. But anyway, it shows that ESPB is good for rib fractures. And my clinical experience also, I have performed ESPB for ICU patients with multiple rib fractures, and it definitely works, improves pain control, and the patients can take deep breaths. And this is the use of ESPB in the emergency room. In the emergency, it's not that easy to have anesthesiologists visiting every patient and intervening every pain patient. But this is a rather simple technique that even I think emergency physicians can perform. Of course, it can be a subject of another discussion, but the conclusion is that ESPB works for rib fractures. And this is a study for paravertebral for rib fractures, paravertebral, thoracic, epidurals, and serratus anterior plane block, they all work. And when it comes to ESPB, ESPB also works. If you do a ESPB and favorably, if you place a catheter, and then you can do intermittent injections, and if you like, you can do a continuous infusion plus bolus doses. ESPB is definitely good for rib fracture patients, and it is technically simpler and easier. Now this is kind of a review and recommendations for rib fractures. And if you look at the anterior and lateral fractures, serratus anterior plane block has been recommended. For posterior and lateral fractures, ESPB is recommended, but of course you can do serratus anterior or paravertebral. And for bilateral fractures too, ESPB is one of the good alternatives. So simply for rib fracture patients, ESPB provides analgesia for unilateral or even bilateral fractures, trauma. It provides analgesia of the anterior and posterior hemothorax, and it can be performed in any position. It is technically easier because it's much superficial than the paravertebral or intercostal or epidural. It can be inserted even in the emergency department, and there will be less hemodynamic disturbance compared to the competitors, and lower risk of complications, especially in the anticoagulated patients. This is very important because we are in the era of anticoagulants, because many patients are using anticoagulants for different reasons. But if you think of the post-COVID era too, then we have another strong reason for the widespread use of anticoagulants. That's why ESPB is definitely an important alternative in regional anesthesia practice for thoracic analgesia. Now, of course, there are lots of critics too about ESPB, lots of publications besides lots of critics, like Linguist has done. Many people are skeptic because people think we do something simple, but it works. How come? They find it difficult to believe. And then the simplicity should not be a disadvantage. Actually, it's an advantage for the anesthesiologist, because if you think of paravertebral block, or if you think of the thoracic epidural, actually not all the anesthesiologists are willing to do these thoracic interventions. But on the other hand, thoracic ESPB is technically much simple block. There is no worries about coagulopathy. But if you think of thoracic epidural, then especially in this age of anticoagulants, of course, there are limitations. There are technical difficulties, and the experience is unfortunately a problem. If you are not doing it every day, you may not want to do it. And of course, no need to say that thoracic epidural has potential serious complications. And as it has been explained earlier, the failure rates are unfortunately high for thoracic epidural. This is a recent study. They performed the epidural in the preoperative holding area. It took around 20 minutes. And if you do it in the operating room with more stress from the surrounding, then it takes 26 minutes. And failure rate, it is 16% in the operating room, and in the preoperative area, it's around 5 to 6%. Now, this is unfortunately serious complications coming from the old days, 1998, intrathecal catheter placement or intrathecal drug administration with epidurals and paraplegia and permanent neurological injury, unfortunately. And it is a subject of discussion. It's a topic, how to prevent the nerve damage during central neuroaxial block. but we don't have such a discussion for ESPB. ESPB, as long as you do it correctly, you are not that close to the neuroaxial structure. So it is nothing that you can compare. And that's one of the reasons why people are using ESPB. This time, 2 case reports. The year is 2021 from this year and from Germany. Now, 1 epidural in the spinal cord itself and 1 epidural hematoma. So these are very serious complications. Of course, it doesn't happen every day, but it is a potential complication. What about paravertebral blocks? Paravertebral blocks are, of course, old, reliable blocks. We know the mechanism of action for sure. There's no discussion about it, but they are technically challenging, especially if you skip ultrasound in part of an area where there is no ultrasound. Then, unfortunately, the number of people performing paravertebral block is few. Actually, it is the ultrasound which has increased the performance of paravertebral blocks. Now, more and more people can do it safely, but there are some potential complications we have to be aware. Of course, one is pneumothorax, because we are just above the pleura, so close, as we have seen in the Manoj movies. And sympathetic block, sometimes it is good, but sometimes we don't want this sympathetic block and the hemodynamic response to it. And the same thing with epidurals, of course. And unfortunately, a serious complication, total spinal anesthesia, can happen with paravertebral block too. And the risk of failure, unfortunately. This is total spinal block after thoracic paravertebral block, and another cases, total spinal anesthesia following paravertebral. So it's a big complication in the hands of anesthesiologists. Of course, we can cover and manage, but still there are potential serious complications. Failure rates, especially if you skip ultrasound, if you forget about ultrasound, you do the paravertebral block and expect that it works. But we didn't really know the failure rates, or in other words, we didn't know the exact success rates. And in one of the previous lectures, it was said it was 28% the failure rate. I have just updated my slide. And total spinal anesthesia is a devastating complication. Pneumothorax may happen. Epidural or spinal spread may happen, but this time actually we don't consider it as a complication, and it's a mechanism, it's a way of mechanism of action, and some hypotension and bradycardia we may expect, of course. This is a very nice picture from Ki-Jae Chin, where he compares epidural anesthesia, paravertebral, and ESPB. And to be fair, as a regional anesthesiologist working in this field, we know that epidural anesthesia is much stronger. Then comes paravertebral, and then ESPB. And with these interfacial plane blocks, and also with ESPB, there is great variability of the clinical effect. And I tell you something, that the clinical effect does not always correlate with the anatomical studies always, because anatomical studies conflicting results, but in the clinic we say that ESPB works. So it is probable that the dye spread does not parallel to the clinical effect, what we see in real life scenarios. So I would like to greet all of our colleagues who are attending the meeting. This is a greeting from sunny Istanbul. Here you can see the bridge connecting Asia and Europe. But of course, we all have different views, and we may want to have a look at the same view with different eyes. And some may see the funny fisherman on the same screen. So maybe this is how we look at the blocks, ESPB, paravertebral, and epidural, and we all had to defend something different. But these are all included in our armamentarium, and we have to choose the correct technique. Thank you very much for listening to me. I will just make a brief summary. ESPB, from my eyes, is effective for thoracic pain, and we use ESPB almost routinely for great majority of our patients, thoracic, breast surgery, and so on. It is technically easy. It is not a disadvantage, but it is an advantage so that many more anesthesiologists in the whole world can use it. Regional anesthesia is widespread used. It contributes. It is much safe, nothing comparable when it comes to safety to the competitors. There is no hemodynamic change, even if you do it bilaterally. And just a reminder, if you remember the picture with the ESPB, paravertebral and epidural, ESPB should be considered as part of multimodal analgesia. So you should definitely give some systemic analgesics to have a superior analgesia. And thanks for listening to me.
Thank you, Yavuz, for a very balanced discussion about ESP block. I think if I were a participant attending this, I think you would have got a real balanced opinions and literature review of the various techniques that we've been discussing today. I think this could probably be described as one of the first. I think it was very well presented by all the speakers, the pros and cons. And although there are some limitations with one or the other technique, I think this is expected in regional anesthesia. So at the end of the day, the operator has to look at many aspects, as Professor Boezaart had alluded to in his presentation. And one of them should be how experienced you are in doing what you do. So before we go into the details about the various discussion, I would now like to welcome Dr. Rossini Wong to present some of the questions that the participants may have. And I can see that all our speakers are here. Michael, can you please unmute your microphone, please? And Dr. Boezaart too?
Unmuted.
Thank you.
Yes.
Dr. Rossini, fire away.
Yes, thank you for all the speakers. We have a question from Dr. Thoracic. I believe it's for Professor Boezaart. So they're asking, how would a stimulating catheter prevent epidural failure due to anatomical issues in the epidural space?
Well, thank you for that question. We started way back in the 90s to do epidurals for children, even for shoulder surgery. And we saw that if you go do a caudal and you just push the catheter up, you can see the segments as the catheter goes up if you apply a nerve stimulator to that. Now, Professor Longquist and all the others have applied nerve stimulators to the paravertebral block, and with great results back before the time of ultrasound. And now we have, for a long time now, we've done stimulating catheters in the epidural space, and you can exactly see where the epidural catheter is by looking at the exact segments that you're stimulating and also the exact side that you're stimulating. Sometimes the catheter goes out of a neuroforamen and you only get stimulation on the one side. Other times it's nice in the center, you get stimulation both sides, and we're using it almost routinely now for epidurals, and we're certainly using it for cancer pain, because you can place the catheter exactly where the pain is, because the patient will tell you this is where the pain is, where the stimulation is. So it is just the same as the thoracic paravertebrals were in the 90s or the early 2000s. We just added a stimulating catheter to that. And there's a lot of literature, especially from Bansui and those guys, that have proven that the incidence of failure come down from 30% to 0% if you put an epidural, if you put a stimulating catheter in the epidural space. The only problem is the catheters we had were flimsy catheters, and if you pull them out and they break and the part of it stays in the epidural space, you end up with red ears and you end up embarrassed. So that was, there was a lot of bad press because of that, and certainly in my practice, I was also scared of putting a StimuCath because it's a flimsy catheter with open coils at the end, to put that in the epidural space. But since then, there have been a bunch of catheters developed that are exactly the same as epidural catheters, except they have a stimulating tip. So you don't have that problem. Now, Bansui has placed a saline inside the catheter, use the Johans connector to stimulate. Other people use the stylet in the catheter to stimulate. We find it much easier just to use the Payun catheter or the arrow stimulating catheter, I think they're called UltraCath, and that works like very, very nicely. So, but
thank you, Andre. That was a good insight into the epidural stimulation. But for the audience, if you contemplate on using epidural stimulation, it has its own nuances, and you have to learn to use it. It's not like just going and starting stimulating. I use it all the time in neonates. It surely, to address the question, how does it reduce or improve accuracy, is, as Professor Boezaart said, by stimulating and looking for myotomal response, you will know exactly where the tip of the catheter is. So depending on your target level of analgesia or where you want your catheter, epidural stimulation is today, I think, the most accurate way of getting to know where the catheter is at the point of care. However, you must remember you need special nerve stimulators. You need higher currents than you are currently using for peripheral nerve stimulation. Currents sometimes up to 8-10 milliamps have to be used because the resistance is very high. So that's a discussion for another day. Okay, do you have another question, Rossini?
Okay, another question for Professor Boezaart from an anonymous attendee. They would like you to explain further why you recommend beta-1 agonist and not alpha agonist for treating hypotension from epidural.
Well, again, when you block the nerves associated with the sympathetic nerves, you also block the sympathetic nerves. And normally, if your carotid body tells you that you have less flow to your brain because of a low blood pressure, you would normally activate your sympathetic nerves, and that would give you an increased cardiac output, and that could also, in some cases, give you it'll give you an increase. So anything that increases the cardiac output would normalize that blood pressure, and the most common one would be fluid, increasing the preload. That would also increase your cardiac output. So fluid would be, a normal volemia would be the first attack. Secondly, anything that increases cardiac output, certainly alpha-1 stimulants in low dosage, and that's got a name, it's called epinephrine, or even dopamine. But we are now using intralipid almost routinely for this, and that also comes from the work of Bansui, and we find it extremely effective because intralipid we also know that intralipid increases the cardiac output, and it's safe, and it's very well, it's used all over. So our attack to hypotension would be correct the fluid balance, then give intralipid, and if then we still have a lower blood pressure, we jack up the cardiac output, and we never use pain to jack up the cardiac output, because that's what typically happens. Surgeons or the intensivists just pull the epidural out and then give the patient pain, and that corrects the blood pressure immediately and very well.
Yep.
Thank
Next
you.
question, please.
Okay, since we're on the topic about management of hypotension for intralipid, actually there's a attendee that would want to ask the opinion from all speakers, whether or not you all routinely use intralipid for hypotension with central neuroaxial blocks, and what would be the regime recommended?
I think I will answer this question on behalf of everybody. I think this is a very experimental therapy at this stage. There is very little information available, although there is some common sense and mechanism that it may be beneficial. So until more literature is available, I would just stick to what you are familiar with in the clinical situation.
Okay, thank you. There are several questions about ESP. I think I'll just pick the few interesting ones. So, so there's a question from
Roshini, if you just let me,
yeah.
I think before we get into the discussion, we talked about thoracic epidural, paravertebrals, and ESP. Yavuz Bey, if you allow me to, I may just summarize all this and then we can take this question because this has to be discussed in relation to some of this. ESP is no denying technically simpler than most of what we perform today. However, the mechanism is still not very clear, particularly when you look at its effects on the anterior rami of the spinal nerve. The effects on the anterior rami of the thoracic spinal nerve is very variable, and extremely variability is what most of the literature suggests, and it is also inconsistent. It appears to be time and volume dependent, so as some of the studies have shown. Most of the time, the cadaveric spread and the anesthetic in sensory spread is confined to the posterior part, which is consistently shown in different studies. And its effects on the anterior rami is more variable. When it comes to, say, thoracotomy, there's no denying that in randomized studies, they have shown efficacy, but we don't know how this efficacy is produced, given that it may not affect the anterior rami. Also, it may be that in thoracotomy, the effects on the dorsal rami, which is significantly affected when you do posterior lateral thoracotomy, where the dorsal rami contributes to the afferent nociception, and then the IV systemic effects of the local anesthetic may be contributing to another effects of this. So with this background, I like to relate a story. It's a very short story, but it shows how the world goes round and round, how science goes round and round. In the year 2000, I was in Cebu in the Philippines in one of the Asian meetings, anesthesiology meetings, and I presented some work relating to thoracic paravertebral block and multiple fracture ribs. Then a very senior gentleman came up to me after the talk and he said, "Oh, that's very nice way of providing good pain relief. I come from Mindanao, which is a very far-flung island, and when we have patients with fracture ribs or patients with renal colic, including gallbladder colics, cholecystitis, what we do is we take 20 cc's of bupivacaine and we put it in the thoracic region and hit the bone and then inject 20 mils of bupivacaine. Although this is not described in the literature, but we find that the patients have excellent pain relief. So I think this is way before Dr. Ferrero really described its effects on, and this could be related to an ESP injection in the thoracic region. Now, obviously nothing is novel. It just means that you haven't looked hard enough. In fact, most of this work have been described by the German group with the retrolaminar and similar injections, very close to where the erector spinae plane injection is performed. Now, given these background, I hope I've summed it right, summed Michael, Yavuz, etc. So, Rossini, what are the questions you have now? Be more appropriate to present it now.
So a question is asking whether, from Dr. Vera Lim, whether or not there'll be an INR threshold for the insertion of ESP block. So since it's a more superficial block comparatively.
Yavuz, would you like to address that, please? Can you unmute yourself?
Yeah, sorry, I didn't get the question. Sorry, could you please?
Okay, that's fine. So Dr. Vera Lim would like to know if there is an INR threshold for the coagulopathic status of the patient, above which you would not perform ESP block.
Yeah, the main, I think this is one of the main advantages of ESPB, because just to make it very simple, we perform it in cardiac surgery patients, and we give them heparin afterwards.
Mm.
So, except the extreme ENR values, you can perform ESPB. So that's maybe one of the advantages. The same with maybe liver surgery, hepatic failure patients, patients undergoing liver transplantations. They can be also the cutting edge of ESPB blocks, but they would also benefit, I think, from ESPB. So even in patients undergoing cardiac surgery and receiving heparin, because they will be lying on their back and there will be pressure applied physiologically, you can perform ESPB.
Okay.
Maybe I can take this discussion in a little bit different way, is that, yes, there is a lot of literature now showing that ESP block is effective for postoperative analgesia in, say, sternotomy surgery, in cardiac surgery. Now, given that it has such variability in its effects on the anterior ramus, do you think most of these effects is because of the systemic effect of local anesthetic? It would seem so based on the evidence that we have. Yavuz Bey?
Well, actually, some other studies, I shared some studies administering local anesthetic at different body sites by surgeons. It does not have the same effect. So I don't agree. Of course, giving IV lidocaine has analgesic effect. That's clear for everyone here, for all the regional anesthesiologists and for pain doctors. We know it for sure. And we know that some of the local anesthetic will be observed. So we will be having these, just as they are observed in the lymphatic system too. We know that some will be in the system, IV systematic absorption there will be. But still, there is another way that ESPB works. So posterior MI, anterior MI, some amount in the paravertebral, some amount in the epidural, especially if you do it bilateral, then I think it's a little bit different. It becomes a different issue, because if you do it bilateral, that we do it in cardiac surgery, then it is the clinical effects are very clear. The patient will have sympathetic block to some extent, because you will see that the heart rate drops, blood pressure drops. There will be vasodilatation of the coronary arteries if the patient is undergoing cardiac surgery. This is what we observe in our clinical practice. So it is beyond actually the absorption, IV absorption of local anesthetic. But of course, IV local anesthetic absorption will have some analgesic effect too, but it is not that simple. Otherwise, this technically simple technique, as you said, Manoj, you told us the story, otherwise wouldn't be so successful. I mean, it's not epidural, we know it. We have to put it into correct place. It is not paravertebral block, but it is quite similar to paravertebral block for relatively minor surgery. But if you do thoracotomy, it is different issue. So it's always used as part of multimodal analgesia. So it's not good enough that you do ESPB and forget it. You have to give some systemic analgesics too.
I think you are absolutely right. We must not, we are not here to argue that this is better than the other or one technique is better than the other. Simplicity is good, efficacy is good. So when the experience is not available and simplicity is, then I'm all for it. But sometimes where scientists, you want to know exactly how it produces the effects. But that said, I think the more techniques you have in your armamentarium, the better. And if you can safely deliver it, it is better too. So here, would you like to give a rebuttal or say something, because you've been one of the debatants?
Well, I think it's been a very nice overview of the various techniques. I've written together with yourself that it's very difficult to tease out the effect of the fascial plane blocks, including the ESP block, without having comparator groups that do in fact get intravenous lidocaine or something similar. And I think that this hot off the press study showing that if you randomize renal transplant recipients to either a tap block, which is more neutral ground, and to intravenous lidocaine, there is no difference. So also looking at the extremely rapid absorption from the ESP plane, I think that the author of that study really has some merit to their conclusion that this might be one of the more major effects of the block. So I think that I don't have a problem with certain studies showing a little bit of dye spread into the paravertebral space. That can happen for a number of reasons. But the problem is that it's not reliable spread. So I don't think that saying that it works through the anterior ramus is not true. I think that that is not true. And then it can work for other reasons, but it's not working through the paravertebral space and not through the anterior ramus. So I think that can be concluded from the studies performed so far.
So
But,
I think what you say is that.
Studies.
So just to summarize your thought in a single term is that ESP has been described as a paravertebral by proxy block. I think the evidence today would say it is not. It has potential to spread to the paravertebral space, epidural space, intercostal space, and so on and so forth. But I think for the anterior ramus involvement, its effects are very variable. And as Michael has extensively alluded in his wonderful presentation, that's this extreme variability cannot be used on a consistent basis for an anterior ramus related procedure. But the evidence from all the studies do show that it is effective. So if analgesia was the primary outcome, whatever mechanism it is producing, we don't know the exact, but it may be, if I may use the word, it's a multitude of effects that produces the final product that it produces analgesia. Would you say that, Michael? You've been very quiet.
Yeah, I think it's primarily a dorsal rami block. And I agree that there's lack of consistency with spread anterior. And maybe the absorption is really a contributing factor. And I think we really need some good quality trials to tease out the effects, contributory effects of systemic absorption.
Now, let me take the discussion a little further in light with some of the new anatomical information. Here, don't worry, I won't give it all away. So, is the existence of the retro-SCTL space, actually, Dr. Hong and his group have already shown that the ESP plane communicates with the paravertebral space or the epidural space via the retro-SCTL space. So while we are trying to discuss its efficacy through standard mechanisms of action, we've never considered that there is a conduit which is directly communicating between the ESP plane and the epidural space. So any local anesthetic that you inject, large volumes will get to the epidural space. And with the kind of volumes that are used, 25 to 30 ml, and given that the conduit's distance from the neuraxis is not far, I think, in my view, epidural spread does contribute significantly to the efficacy of a paravertebral, of a ESP block. And mind you, the investigators from Korea, Dr. Hong and the group, have shown that the dorsal rami, the ventral and dorsal rami of the spinal nerve actually are outside the paravertebral space, or in fact, the ventral rama is outside the paravertebral space initially before it enters the paravertebral space through the medial slit. So even low concentrations of local anesthetic, if it gets to the dorsal root ganglion, and Andre, you showed the pictures about the dorsal root ganglion and its proximity to the foramina. And with the dorsal root ganglion being an important modulator of afferent nociception, even in low concentration, may modulate pain. This is not often discussed as part of the mechanisms. And I think this new anatomical information will have some role to play in our better understanding many of these so-called paravertebral by proxy blocks. These were my thoughts. Anything you have to add on to that, Yavuz?
No, I think you have made a very clear and nice explanation. Because we did talk about today ESPB, paravertebral and epidural, but you know, there are other blocks which are done around the paraspinal blocks, or how you would like to name. And in all of these blocks, the target should be the spread of local anesthetic to the to some extent to the paravertebral, to some extent to the epidural, and maybe they don't make big changes. So I don't want to name these blocks. And also there has been some modifications of ESPB. Like if you are closer to the costotransverse ligament, closer to paravertebral, it maybe works better. Then we are aiming paravertebral. So if you, just as you say, Manoj, if you can see the paravertebral area, can do it technically, why not do the paravertebral? So all these local anesthetic using different approaches to ESPB or different paraspinal blocks, probably they act via paravertebral or epidural spread, at least to some extent.
That's a well summed up summary. Rossini, any further questions that you have?
Yeah, Dr. Ali Safras, since we are talking about the communications of the spaces for ESP block, this attendee is asking if there's chance of catheter migration into the epidural or intrathecal space after an ESP block catheter placement.
Yavuz, you must have to answer this question because I don't put catheters with ESP.
Catheter dislodgement is not a problem. It's the catheter placement is technically easy because one of the main advantages, it is superficial. Erector spine, especially if you are doing it now. Today we are talking about thoracic, and at the thoracical level, it is much superficial and technically easy. Yes, Per, you want to say something?
No, I just have to dash off. So my time has run out. So thank you, everyone.
Thank you, Pier. Thank you, Pier, for joining in. And we appreciate your contribution. Keep up the good work and stay healthy. Yes, go ahead. We have another 10 minutes.
So that's all from me.
Okay. Any other questions? Yes, Andre?
No, I just wanted to sort of facetiously say, back in the day, you know, when you and I were kids in the 80s, they came with all sorts of stuff around childbirth. You know, they came with Le Boyer deliveries and all sorts of fancy ideas. And back in the 80s, I told these guys, and which I would like to also tell these guys now, when you run out of fancy ideas, just come back to me and I'll put an epidural in for you and that'll solve the problem.
Yes, that's perfectly said, Andre. Wisdom grows with gray hair, I guess. Michael, do you have any final comments?
Yeah, I'd encourage the readers to take a deeper dive into the quality of the randomized controlled trials on Erector Spinae block. It's something that they need to make. It's an evaluation that they need to make themselves. And I'd encourage the attendees to look at the quality of the studies, including whether the investigators used multimodal analgesia, whether there was appropriate blinding of observers, whether there was a good description of randomization and concealment of allocation. Many of the trials are actually flawed unfortunately, I regret to say, and I say many, I don't say all, some of the trials don't have consort diagrams. Some of the trials don't designate a primary outcome. Some of them have really broad exclusions such that the trials are hardly generalizable to the patients we look after every day. Many of the trials have multiplicity of analyses. Some of the trials do not have trial registration, and very few of the trials have a sham block. So I would encourage the attendees to look at the quality of the trials of the interfascial plane blocks and make a judgment for themselves. Because during these presentations, occasionally I get the sense that people think that evidence-based publications are the truth. And the reality is that most evidence is temporary, most evidence is fragile. And what we're really lacking in this whole development of interfascial plane blocks is we're lacking large, pragmatic, multi-center trials. And I think that's what we need. These small, randomized controlled trials with 40 patients per group is not really helping our specialty. So that's what I would encourage the attendees to consider. For this particular block, the mechanism of action is critical. It's easy to generate p values less than 0.05, but they don't have meaning unless we understand the mechanism of action. So that's it.
Yeah, I think you sum it very rightly from an editorial point of view. I think there are a lot of publications. We have to be prudent in what we take home, and eventually you deliver it to your patients. So you have to be responsible for that. But nevertheless, although the data is conflicting, but it does point to the fact that it is a new kid in the block with various mechanisms we still don't understand. It's no denying it is technically very simple, but as somebody wrote, being simple doesn't mean you should be using it. Sure, it is technically simple, and if it has an efficacy, I'm all for it. But I think we need to know more about it as to how it produces this block, particularly when folks are publishing work that we have been unable to demonstrate with epidurals, with paravertebrals, doing surgical anesthesia as a surgical anesthetic technique. And Yavuz, you referred to a paper by some folks in the Indian Journal of Anesthesia using it for surgical anesthesia for breast surgery, given all the variability in its effects on the anterior rami. I thought the first case report by the group from Canada in the anesthesia practice in ANA journal on the use of ESP for breast surgery was maybe a fluke. You can have a lucky day and you have a good effect. And given that it produces epidural spread, that could be the lucky patient. But to be able to do it consistently in 30 or 40 patients as reported in the literature, it just bogs me to understand how this could be possible. Could it just be the sedation that Yavuz Bey described about? So these are a lot of things, and we will be discussing more about this in the next webinar, particularly relating to many of the best practices for breast surgery, for hip, knee, and shoulder surgery. So I welcome you all again to that. Since it's getting a bit late for everybody, and in particular, Michael, although you look like it's sunny Portland behind you, but I can assure you it's early morning. Thank you all for sharing your time and for joining in, to Yavuz, to Professor Boezaart, to Professor Barrington, and Professor Lundquist, and Hang. Also, Rossini, thank you for your time. It's been a great few hours. And we still haven't really come to a consensus. I think this is what is wonderful about science. We have our own opinions, and we try and do what is best for your patients. Thank you all for joining in again, and I hope to see you all again in 2 weeks' time. Take care. and stay safe wherever you are in this world. Bye-bye for now.
Thank you, Manoj. See you.